Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen, all esteemed professors, urologists, other specialists, residents, general practitioners, and all medical students who are joining us right now. Allow me to introduce myself. My name is Hosea, and I will be your host for tonight's event. Welcome to Jakarta Urology Medical Update 2020, in conjunction with Annual Scientific Meeting of Continent Society of Indonesia. This is a series of events organized by Yayasan Pengembangan Urologi Jakarta throughout September until October 4, discussing various topics in urology. And we are glad to say this event will also support the COVID-19 relief effort in Indonesia by donating some of the registration fee. This is the first day of our 6-day webinar, where we will discuss all about andrology urology. And without further ado, let's begin tonight's event by hearing the opening remarks from Dr. Irfan Wahyudi as the head of Department of Urology, Faculty of Medicine, Universitas Indonesia and Cipto Mangunkusumo Hospital. We would like to welcome Dr. Irfan.
Thank you, Dr. Hosea. Assalamualaikum warahmatullahi wabarakatuh. Good evening. It is an honor for us, the Urology Department, Faculty of Medicine, Universitas Indonesia, to hold this annual scientific event. This year, the implementation of this event is quite different. Instead of physical meeting, this year we arranged virtual conference due to COVID-19 pandemic. Frankly speaking, we had quite a long discussion whether this year we will hold this event or postpone it. However, due to enthusiasm and high motivation from our staff, our organizing committee, we finally agreed to continue to hold this event. We changed the name of this meeting to JAM, as you all see. It's a Jakarta Urology Medical Update as a rebranding from our previous name. The reason for it, as proposed by our organizing committee and our young staff member, is to make it sound more energetic and vibrant. There will be 6 sessions. One session every week, starting from today until October 2020, discussing the latest topics in the field of andrology, endourology, urological oncology, functional urology, and kidney transplant. This event is also in collaboration with Perkina, Continent Society of Indonesia, which also make this event as their annual scientific event. There will be a number of international speakers, at least 7 people will participate in this event. And I would like to thank Dr. Asif Munir from the University of College Hospital London and Faisal Yafi from UCI Urology, Orange County, USA, who agreed to become our guest speakers for the first session of this annual meeting. It is a privilege to have you both to share your expertise and experience with us. We are sorry if the timing of this event is not suitable for you. Also, I want to sorry to disrupt your beautiful Sunday. I would like to thank Dr. Vina Widya as the chairperson for this meeting and all organizing committees members who have worked very hard from the preparation to the implementation of this event, and also to all parties who contribute to this event. I'm sorry if I don't mention all names because of the time limited. We know that there are a lot of webinars and virtual conference nowadays, but we hope you all don't get bored and still have energy to follow and enjoy all sessions without any technical disruption and obstacles. Stay healthy. May God bless us Billahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Irfan, for the beautiful opening remark. And now, let's start our first topic about ethics and patient safety in urology. This topic will also be brought to you by Dr. Irfan Wahyudi. But before we go back to Dr. Irfan, let me tell you a little bit about Dr. Irfan. Dr. Irfan was born in Jakarta, July 15, 1971, graduated as medical doctor from Universitas Indonesia in 1995, as a urologist also from Universitas Indonesia on 2005, and he finished his doctoral program on Faculty of Medicine Universitas Indonesia on 2013. And Dr. Irfan currently active as the head of Department of Urology, Faculty of Medicine Universitas Indonesia and Cipto Mangunkusumo Hospital. And we would like to welcome back Dr. Irfan. The time is yours.
Thank you again. Maybe the host can share the slide. Okay. I will talk about ethics and patient safety in urology during COVID-19 pandemic. To be honest, it is a hard topic. I'm not expert in this field. I'm also not ethics committee member, but I accept this topic because it is relevant to address with our situation right now. Okay. As we know, ethics of our profession consists of 4 principles. First is intention of doing good for the patient best interest. Second, we known as primum non nocere or do no harm. Third is patient anatomy. And the fourth is justice or fairness in gaining information and decision making. Next. This is the more detail about medical ethics, concepts and values that we have to full respect for the dignity of our profession and also as a man. We don't have to put conflict between financial interests and medical interests of the patient. We should expose without fear or favor incompetence or corrupt, dishonest, or an unethical conduct on the part of the member of profession. Shall observe the law of the country in regulating the practice of medicine, implied consent and informed consent, and also legal, ethical, and moral liabilities of the doctors are enshrined in the Hippocratic Oath. This medical ethics values has been accepted and adopted as Kodeki by Indonesian Medical Association or ED in 2002. Next. As we understood, now we face COVID-19 pandemic with all devastating consequences. This have a seismic impact on our medical surgical services function. Globally, millions have been infected, hundreds of thousands have been died, and among them, sadly, many frontline healthcare workers and surgeons. We know that this also impacts patient and doctor relationships because we have a burden and limitation of our healthcare system. And we as urologists face these unique specialty-specific challenges during this pandemic. Next. If we see the perspective from the ethics on beneficence, non-maleficence, and best interests, our goal actually is the primacy of patient welfare. It is our foundation of medical ethics, and we have to assure that those values form the bedrock of medical professional codes. Doctors have primary responsibility to act in patient-best interests, and patient must have trust in us to do the right things. But during pandemics, individual best interests must come secondary to that of society. There is a limitation or even moratorium on surgery, except only in emergency case. Indirect harm can be caused by the postponing treatment, and balance increase should be considered between risk complex surgery and contraction of COVID-19 in the perioperative periods. Next. But with this situation, we see that as a human, we fight and we make an innovation. Thankfully, that we as human now have advancement in IT. So we can do something against that. Many hospitals now apply green or can say clean zone or area or hospital specific for non-COVID patient services. Also, we can make a modification of treatment for non-COVID patient. We can evaluate again our protocol, and maybe we can reduce the time in inward during hospitalization, or even we can change our policy in the treatment or surgery. Also, the society talk and discuss and make a consensus for triage and prioritization to identify procedures that can be postponed. And we can also make a scoring system for surgical schedule. Next. This is sample the effort of the society from the urology, where we can make a comparison of the parenting urological society. Let's say it is from the AU guidelines, from the British, and from the USANS about what is the low priority, moderate, and high priority. Next. Next. The other way to face the situation is make a scoring for the prioritization of the operation surgery. We can see that this is one of the comprehensive scoring where involve not only the disease factor, but also consider the procedure factors and also the condition of the hospital. So we can make scoring from this, and we can divide the patient to the priority, like we can see in the left side, and we can make a low priority like we can see in the right side. Next. The other impact on the aspect of ethics on altruism and duty is because surgeons called to help patients and support the colleagues. But on the other side, COVID-19 hospital-based transmission occurred, and surgeons face particular risks due to intimate physical proximity and contact with potentially infectious body fluid, blood, urine, and also feces. And now, to face this situation, we as a urologist should have a role in maintain emergency surgical capabilities to protect and preserve the surgical workforce, and also we can also work not only as a urologist but for other roles. Maybe if there is a lack of the condition or lack of the number of the doctors or medical healthcare in, let's say, in the laboratorium, can help them to put or to take part in the taking sample from the patient, for example. Next. We can also take a role to protect ourselves by using PPE, also minimum number of theater staff, so we can reduce the number of personnel in operating theater. We can make a compromising the service by postpone all elective cases where the endemic and the number of cases is very high, and we have already overwhelmed with the cases with COVID-19. We can minimize face-to-face consultation using telemedicine or teleconference, something like that. And also for the education, we can use a virtual meeting. In endoscopy, there is a little evidence of minimal invasive surgery risk specific to the COVID-19, and it is proven benefits of reduced length of stay and fewer complications. And we can use smoke filter to filter release of the carbon dioxide, and we reduce the energy device to lower setting energy. We can also make practical measures like a constant coverage of COVID-19, and it is advisable. It is advised to test all patients before surgery. It is best to test all patients with PCR, with swab. And it is also good to have a dedicated OR with negative pressure for COVID-19. For endoscopy, all staff should wear PPE and avoid little complicated or too complicated advanced procedure. Next. This is guidelines, option how to choose the PPE during a different zone, different condition, and what type of PPE we should use. And it is available in the internet. It is free and you can use it. We can also have a guideline from our Ministry of Health, or even our local hospital usually make a guideline. Next. Impact on autonomy and informed consent, also one of the consideration, because actually the concept of ethics that surgeon-patient relationship should be considered as a partnership, and it is our duty to be honestly educate and empower patient to make appropriate informed choices about surgical care. But during this pandemic, some choices must be restricted or even withheld. We don't have ability to offer different kind of surgery, for example, because of our limitation. And also we have a burden. We have a problem with communication because we have used the PPE, and sometimes it is very difficult to hear or to communicate with the patient because we use masks or because we use visors, and also because we cannot do uh, we can we can near the patient because we have to uh, make a social distancing and isolation, and also the from family and best friend patient cannot meet. Many challenges to inform consent, including patient barriers because of the age of the patient, education, language, illness, and disability. And also there is a barriers in the process, including the forms, information, communication, and timing. Next. But in that situation, there's also innovation. We can see that now many center develops their own surgical consent checklist to complete the standard checklist for the informed consent that include the risk of the patient should be considered if they go through with the perioperative process. The possibility to contract it with the COVID, and also all the procedures that should be added to evaluate as a screening process. So this is all innovation, all effort that we can do to uh, resolve or to improve our services during this condition. Next. And because of our limitation, we are, as a urologist, should be as fair as possible. We have to explain about our hospital condition, about our limitation when offering treatments to the patient, and about our limited medical resources. During pandemic, the individual patient-based interest, we have to become secondary to that society as a whole. We should consider the available resources and the needs of all patients while taking care of an individual patient. And the positive effect of this pandemic is that we, as a surgeon, we have to collaborate with healthcare providers to work and creatively save and sustainable restore surgical services. Maybe because of the burden of the patient COVID, we have to adjust our OR room, our OR time, or even our nurse because of the limitation of the working hours and also for the safety of us. Next. This COVID pandemic also have effect on our ethics in confidentially conflicts and medical mistakes. Confidentially is integral actually to our patient doctor trust. We have witnessed a parallel outbreak of social media usage and exploration of novel video conference in healthcare, and it is uh, should be disseminated. The experience and research must be disseminated to ensure care is evidence-based, because it is unprecedented time. Maybe we don't have evidence-based research before, but with collaboration with the advance of the IT, we can make like a society and gathering to collect the data, so we can have more evidence, more robust evidence to our health services. But we have to follow the principle of research ethics. We have to ensure that consent is still informed, and we have to declare or avoid conflict of interest. And it is should be stressed, should be said that working collaboratively to the best of our humanity, to the best of the patient, to the best of our nation, rather than become the first in the finding. Surgeon must also endure social distancing, and maybe we can have a financial hardship with the loss of the earning, but we have to aware that our health is the most important in this situation. We can also learning how to prevent mistakes, openly reporting mistakes, and learning from mistakes. Next. This is some guidelines and general recommendation for surgical procedures. So maybe our high priority now is for emergency cases. We have to consider our OR, our capacity of ICU beds, also blood supplies, drug shortage in order to prioritize our surgeries. We have to put our priority patient, increase the footfall and the risk of transmission of COVID-19 between patient and staff. Consider that surgery has been reported to be harmful in asymptomatic patient who subsequently tested COVID-19 positive. Treating intermediate priority patient if capacity is available, but not during the surge of the COVID-19. Consider about older patient with comorbidity at a severe risk of COVID-19 infection and fatal outcome. Where ventilator capacity of COVID-19 patient has been breached, high priority surgical candidates requiring ICU ventilation should be triaged according to local recommendation. So this is all should be considered. Next. Next. Can you see the slide?
Yes, we can see your slide, Dr. Ivan.
Okay. So it is also important to testing patient before surgery in the time of this situation. Patient with clinical symptoms like fever and respiratory distress should all undergo the screening for COVID-19 tests. And patient without any clinic symptoms and without travel history in the last 2 weeks, testing of elective patient is necessary 48 hours prior to surgery before the patient go to inward. And it is strongly recommended for patient to comply with general direction regarding social distancing as stated by the government. Next. This is some guidelines for the checklist for the human surgery. We can So in the internet, it is open source. You can open it full text freely. Next. Next. There's also some recommendation that available in the internet. You can see and you can use as a reference. Next. Next. Yeah. Okay. This is all consideration to our perioperative situation to keep the patient safety or also medical staff safety and safety for all. Next. Okay, and as a conclusion, the doctor-patient relationship is one based on mutual trust and respect between two parties. We understood there is a four principle of health care ethics: beneficence, non-maleficence, autonomy, and justice. Pandemic situation has made us in the practice of urology, and adaptation to this unprecedented situation should take ethics and patient safety into our main consideration. Thank you.
Once again, thank you, Dr. Irfan, for the comprehensive materials in ethics and patient safety in urology. And I'm also happy to let all participants know that the recording of all jam sessions will be available on demand after this event is over by watching them on YouTube channel Urologi FKUI RSCM. Now, without further ado, let's start our main session. We will discuss about the update of Andrology urology from our esteemed panelists. So I would like to kindly invite our moderator, Dr. Widi Atmoko, to lead and moderate the main session. Before we welcome Dr. Widi, I would like to let you know a little bit about Dr. Widi. Dr. Widi was born in Jakarta, May 26, 1988, graduated as medical doctor from Universitas Indonesia in 2010, and as urologist also from Universitas Indonesia in 2017, and currently one of the medical staff of Endourology and Andrology Division of Department of Urology, Cipto Mangunkusumo Hospital, Faculty of Medicine, Universitas Indonesia, and head of Urology Division of Universitas Indonesia Academic Hospital. Without further ado, let's welcome Dr. Widi Atmoko, and the time is yours.
Okay, thank you, Dr. Hosia, for being MC today. So today we will discuss about the Andrology session in Jam 2020. And now we have speakers here. We have three topics. The first topics will be about the ESWT will be presented by the Dr. Poncho. And the second topics will be about the penile prosthesis, surgery treatment for the erectile dysfunction will be presented by the Dr. Asif Munir. And the last session will be about how to set up about the men's health center, and which will be presented by the Dr. Faisal Yafi. So I think we can proceed to the first session, will be presented by Dr. Poncho Biro. And I think I will explain about the short CV about Dr. Poncho. Dr. Poncho is a medical staff and also endourology, stone surgery, and andrology in male reproductive and division, the Department of Urology, Cipto Mangunkusumo Hospital. And now he is the Secretary General in Indonesian Society of Andrological Society and also the president of the Indonesian Society of Endourology. And in education, Dr. Ponco graduated as the medical doctor from Faculty of Medicine Universitas Indonesia on 1997 and as urologist from same university on 2005. And he got his PhD degree from Hannover Medicine Hochschule, Germany on 2009. So I think we can proceed to his presentation. So welcome, Dr. Ponco. The time is yours. Okay, Dr. Ponco, so I think we can see your slide. You can start now to present your presentation.
Okay, thank you, Dr. Can you hear me?
Yes, we can hear you, Dr. Ponco.
Okay, I think I already start the slide. Can you see my slide?
Yes, we can see your slide.
Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen, colleagues. This evening, I would have a duty to present about the erectile dysfunction and shockwave therapy. My presentation will be divided into two topics to understand about erectile dysfunction and to understand about shockwave therapy or extracorporeal shockwave therapy. First is the definition. This is a refreshment of our knowledge that erectile dysfunction is defined as the persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. I think in global there is the prevalence about the 15%, and in 2025 estimated that 320 million of men affected with this problem. I made a survey, internet survey, electronic survey, that we found that the prevalence in my survey is about 35.6, divided into mild, moderate, and to severe. This is internet-based, so most of the respondents have a tertiary education, and the age is mean age is 38 years old, and most of them are married. The classification of the erectile dysfunction is, as we know, that is organic, psychogenic, and mixed. Mixed is the most common cause of erectile dysfunction. In my survey, we found that the prevalence of erectile dysfunction is increasing by age. We can see that the age above 50, then the prevalence is about 70% of the respondents have erectile dysfunction, divided from mild to moderate, severe, and this one is they are not complete answer the survey. The risk factor of the erectile dysfunction, we can see that there is age, diabetes mellitus, dyslipidemia, hypertension, cardiovascular disease, obesity, lack of exercise, and smoking. This is the refreshment of the mechanism of the erection. We can see that in the flaccid state, the artery are contraction. And if we have erection, men have erection, that the artery are dilated. So the contraction and relaxation of the smooth muscle in the corpus cavernosus is essential to have a sufficient erection. Let's see how can a smooth muscle can relax. The smooth muscle can relax in many ways. One of the most important is if the concentration of the calcium in the smooth muscle is decreased. How can it be happen? There are two main mechanism. One is the blockage of the calcium pump and the storage of the calcium into endoplasmic reticulum. And this was induced by protein kinase G, induced by CGMP, cyclic guanosine monophosphate. Cyclic guanosine monophosphate was produced from GTP activated by guanylyl cyclase. And CGMP guanylyl cyclase is induced by nitric oxide. Nitric oxide is produced by the endothelial cells and from the nerve, non-cholinergic and non-adrenergic nerve, producing nitric oxide and activate the guanylyl cyclase. Guanylyl cyclase will convert the GTP, guanosine triphosphate, to CGMP, cyclic guanosine monophosphate, and activate the protein kinase G. This cyclic guanosine monophosphate will be transformed to the inactive form 5-GMP by this enzyme, phosphodiesterase 5. If we block this PD5 enzyme, and then the concentration of CGMP will be still increased. This is one of the important mechanism from the medicamentation treatment. So erectile dysfunction and CVD have the same mechanism. So oxidative stress in the cell can induce by dyslipidemia, by diabetes, hypogonadism, hypertension, and smoking can causing oxidative stress, and the stress can cause endothelial cell injury, which lead to the vascular constriction, increased autonomic activity, thrombosis, and arteriosclerosis. This can cause erectile dysfunction and cardiovascular disease. So if we see the patient with the cardiovascular disease, with the diabetes, with the hyperdyslipidemia, we have our hypertension, we have to aware that the patient might have erectile dysfunction. And the contrary, if we found erectile dysfunction patient in our clinic, we have to find this disease also cardiovascular disease, dyslipidemia, diabetes, hypertension, and hypogonadism, because they are sharing the same mechanism. So how can we distinguish between the organic erectile dysfunction and psychogenic erectile dysfunction? Anamnesis can distinguish between the Halo, Dr. Widi? Sorry. Sorry for the technical problem. So there's a question to distinguish between the psychogenic and the organic. In the psychogenics, we can ask about the onset of the erectile dysfunction, and also we can ask the patient whether they still have nocturnal erection or morning erection, and then we can ask about the sporadic erectile dysfunction. It means sometimes the erection is good, sometimes the erection is not good, and then we have to aware that that the erectile dysfunction is because of the psychogenic. And we also have to see whether there is anxiety, depression. In my experience, if the patient have the problems with the law, for example, or there is a bad situation in their business, like in this pandemic, a lot of patients lost their jobs, their income, and then one of the symptoms is the erectile dysfunction. And then if we found probable this patient, and we can suggest to do the nocturnal penile tumescence and rigidity test. Yeah. If the patient have an organic erectile dysfunction, we can ask about the symptoms. The symptom is gradual, increasing in a very slowly, and then they have no morning erection, and the situation of erectile dysfunction is not changes time by time, only getting worse. Never been the patient have no good erection. If we suspect this is organic erectile dysfunction, and we have to divide whether this is vasculogenic, endocrinologic, or neurogenic. Vasculogenic, we have to identify about the hypertension, smoking, is the patient have a hyperlipidemia, diabetes, cardiovascular disease, or is there any history of operation in the pelvic area. If the patient have endocrinologic erectile dysfunction, we have to identify the hypogonadism, hyperprolactinemia, hyperthyroidism, alcoholism, or iatrogenic. If the patient have a neurogenic erectile dysfunction, we have to find the neurologic disease, trauma or iatrogenic, or also diabetes mellitus. So if the patient have already filled the instrument, questionnaire instrument, internalized index of erectile dysfunction, we have to identify another sexual problem, not ED, whether it's the desire, whether there is erectile premature ejaculation. We have to identify that. So also, we have also make identification of a common cause of erectile dysfunction, like smoking, diabetes, and so on, and then identify the reversible risk of erectile dysfunction. For example, smoking, or doing the not doing exercise, less exercise. We have to identify the reversible risk of fracture erectile dysfunction, and also I have to assess the psychosocial status. We as a urologist dealing with erectile dysfunction sometimes have to deal also the psychosocial situation of the patient. And then we focus the physical examination. Is there any penile deformities? Is there a prostatic disease? Same sign of hypogonadism, and also about cardiovascular and neurological status. And then we do the laboratory tests. Yeah, the most important is the glucose lipid profile and also the testosterone. Yeah. The spatial examination. This is we do this examination only based on the spatial circumstances, like injection stimulation, color duplex ultrasonography, and cover nosography, pelvic arteriography, and ambulatory NPT test, rigidity, or we use the Rigiscan. This is the ambulatory penile rigidity test. Usually we ask the patient to stay overnight in the hospital, or they can take this equipment to their house, and then we put the ring at 9 o'clock or 10 o'clock, and then the patient sleep, and the next morning we can see this graphic This is very helpful to distinguish between the normal and erectile dysfunction. If the patient complains of erectile dysfunction, but the NPT test showing like this, it means the patient have the psychogenic cause of erectile dysfunction, and this is not suitable for the ESWT treatment. The treatment option, yeah. First, before the therapeutic suggestion, we have to identify the needs and expectation of the patient. We have to tell the patient that the erectile dysfunction treatment cannot be instant. It takes time, and also have a need of collaboration or effort also from the patient. For example, if the patient is smoking, they have to stop, or they have to quit smoking. If they have less exercise, they have to do more exercise. If their eating habit is not good, they have to change it. The option is, of course, lifestyle modification. And the first choice is oral therapy with PD5 inhibitor. So we have the vacuum device, intracorporeal injection, topical or intraurethral alpostradiol. If we presume that the patient have a vasculogenic erectile dysfunction only, and then low intensity shockwave therapy will be one of choice for the treatment. If all the treatment cannot be overcome the problem, then the penile prosthesis will be one of the choice for the patient. Penile prosthesis will be explained by Dr. Asif Munir. How about the shockwave? If the shockwave produced by just at the beginning, they are produced by the plane who have as speed as the sound, Mach 0.9, and they will produce the shockwave. And this, now for the treatment, the shockwave is produced by electrohydraulic effect, and then focus into the treated area, and then having a spark energy, and then delivered through the focus area where we want to do the treatment. We already know about the shockwave. As urologists, we know about the fragmentation. For the stone fragmentation, we use the very big power of shockwave therapy, around 900 bar. But for the angiogenesis, erectile dysfunction, we use the low intensity. This is 100 bar. Clinical application of the shockwave therapy is very wide, from the urinary stone, orthopedic, cardiology, wound healing, plastic surgery, and neurology. And low intensity shockwave can be used for the cell regeneration, pain therapy, and pseudohysteresis if it is strong and used for the lithotripsy. And then what is the advantage of the ESWT, extracorporeal shock therapy? This is minimally invasive, no clinically relevant side effect, no side effects, induced vasodilatation, induced neoangiogenesis, tissue remodeling, nerve degeneration, induce anti-inflammatory activity, and recruit activation preventative stem cell. So the shockwave machine is, there is a lot of several source of the shockwave. It can be electrohydraulic, piezoelectric, and electromagnetic. And the probe types can be different also. It can be 5 millimeter to 3 centimeters. Yeah, and the penetration is also different. Yeah, we can see this is electromagnetic shockwave, electromagnetic 0.03 until 0.1 millijoule millimeter square. And recent suggestion, the dose is about 3,000 until 5,000 pulse per session, multi-session. More shock phase, better result. Repetition is usually about 12 sessions, 1 until 2 times a week. There is no one treatment protocol for everyone, so we can make individual choice for the each. We have to do it personalized for each patient. This is the evidence base. There is a lot of meta-analysis. This is 5 randomized clinical trials, 282 patients. There is a increase of International Index Erectile Function score after low intensity SVT. If we combine, we can have a better score after we do the ALSVT and then combination with PD5 inhibitor. This is 7 randomized clinical trials. The shock is varies from 3,000 until 18,000. Increase in International Index score, erection hardness score, and severity of ED is reduced. And this is another meta-analysis, 7 randomized clinical trials. But we have to aware that this meta-analysis have a small samples of the patient. And this is the combination between ESWT and then tadalafil for 5 milligram once daily. After 12 weeks, combination have better results ESWTW in the Peyronie disease, in curvature degree, plaque size, pain relief, and International Index Erectile Function 5 score and quality of life. How about the guideline of ESWT according to IAO? ESWT has a weak recommendation because the no publication with unequivocal evidence from additional RCTs, and we need a longer time for follow-up. So there is a limitation of this treatment. The ESV takes quite some time, 12 weeks, but we have to understand that the patient usually wants the instant outcome of the treatment. They want to see a doctor, and then the next morning the erection is getting better. We have to explain to the patient that none of the treatment can be have an instant outcome, and depending on the machine use, the cost can be high. Electrodes from ESWT can be worn out and need to be replaced. As a take-home message, please remember that to treat erectile dysfunction, we have to do first line treatment first. For example, behavioral change and medical treatment. We have to select the patients for ESWT. The best is for the vasculogenic erectile dysfunction. If the patient is psychogenic and it is not suitable for the erectile ESWT, we have to inform the patient about the success rate, and the outcome is not instant. It takes time. Then the ESWT can improve erectile dysfunction condition by induce the neurovascularization, progenitor stem cell, tissues, and nerve repair using the low intensity shock wave. Protocol should be individualized amongst the patient. And since the many ESWT studies show significant positive result, but most of the studies have small sample size. In the patient with no other treatment option, like we already do the first line, second line, and then ESWT treatment can be one of the options. Thank you very much for your attention. Dr. Widi, I return to you.
Okay, so thank you to Dr. Poncho that already explained about the overview of the management of the erectile dysfunction and also the explanation of the the ESWT. So I think we already have some questions, but I think for the participant who wants to ask the speakers can put the questions on the Q&A session, sorry, Q&A box, and then we will discuss on the last session. So after this, we will hear the topics about the erectile dysfunction management with the penile prosthesis. We already have here Dr. Asif Munir. So hi, Dr. Asif Munir, how are you?
Yes, very well,
Can you hear
thank
me?
you. Yes, I can hear
Okay.
you. Can you hear me?
Yeah, I can hear you, Dr. Asif.
Okay. All right.
Okay.
I hope there's no technological issue, but I'll just see whether I can share my presentation.
Okay.
How is that?
Yeah, it's good. Yeah.
Okay. All right. Thank you very much, Widi, for inviting me. And Assalamu alaikum wa rahmatullahi wa barakatuhu to everyone who is on the JUMP conference today. So I was going to just talk a bit about the surgical aspects for erectile dysfunction, and that was a very nice overview with regards to low intensity shockwave treatment. I'm going to look at more what we do with end stage treatment for those who are refractory to all of those options. So as we've already heard, erectile dysfunction is a very common problem. You can see that 50% of men over the age of 50 will report some degree of erectile dysfunction at some point in their lifetime. Generally, as you get older, you'll get more organic issues such as diabetes, prostate surgery. But then in the younger group, you'll get psychogenic. But generally, a lot of men do get a combination of both, but it's just a balance of whether it's mainly organic or mainly psychogenic. So when you look at guidelines, these can be on a local or a national level, or you can follow international guidelines, such as those which have been talked about earlier on, which are the EAU guidelines. And in terms of your sort of local guidelines, you need to decide on, you know, how these men should be managed. So you've got a man here with erectile dysfunction. Do they get managed by their local primary care doctor, or do you send them to a general urologist? You will find that there's going to be some very difficult groups of patients, such as the young psychogenic patients who do need NPT studies or penile Doppler studies. And there you might want to send them to a urologist who's got special interest in andrology. So these are the older EAU guidelines that I was involved with back in 2016. And these are developed from an expert panel, and you look at levels of evidence and use the Oxford Centre for Evidence-Based Medicine, and then you grade a level of recommendation. And as you can see that, you know, there are national guidelines as well that people use. So these were the updated British Society for Sexual Medicine guidelines I was involved with, and these were an update from those from 2008, and these are used nationally with regards to the investigation and management of erectile dysfunction. But generally, most of them will agree that initially men need to have some lifestyle modifications, such as stopping smoking, reduce their alcohol intake, more exercise. You need to exhaust oral PD5s. So you start from sildenafil or tadalafil, but at the maximum dose, at least 8 times. You can then move on to intracavernosal injections, intraurethral prostaglandins, low-intensity shockwave treatment that we've just heard about. If you don't want to have surgery, so if all of these options here fail, then there is always the option of a vacuum erection device if you don't want to have surgery, or eventually you can undergo a penile prosthesis, which is a end-stage surgical option. So your self-injection therapy, I mean, there's different ones. The most common that we use is our Prostadil, but you can get them in combination now, and you can salvage about a third of patients if they've failed PD5 inhibitors. And here you can see this is our Prostadil dual chamber. You put the needle on, you screw this, and the powder and the solution will mix, and then you can inject it into the penis, about 70% efficacy, with VIP and phentolamine, 80% efficacy. The other one is Muse, where you put down the urethra. Again, data shows up to about 70% effective, and it comes in with an applicator that you put into the penis, and you put the little pellet in and you massage it in. But there's going to come a time, either due to disease progression or they've had surgery for prostate cancer, that none of these options are going to work. And this is where we have to start thinking about end-stage surgery. So the penile prosthesis, I mean, it was developed in the early 1970s, and the earlier models weren't great. And you can see over here that they were associated with quite a lot of complications, and the principles have remained the same though. So the materials have improved. They've still got 2 inflatable cylinders, or you can get a malleable rod. But these are the ones, the inflatable ones here on the left are the ones that we do more of. So you've got 2 inflatable cylinders, you've got tubing connecting to a reservoir, and then you've got a pump over here, which has obviously changed over the years. So the modifications that we've had are basically such that the materials and the pump have changed. You've got better material, and you've got coatings which are better. So you can see that it lasts longer, a lower mechanical failure rate. And also the main problem that we have with implants is the infection risk. And with the infection risk, you can reduce it by either having antibiotic coated implants, such as the AMS 700CX, or you have a hydrophilic coating on the implant that you soak into an antibiotic solution of your choice. So this is how implants are developed over the years. You can see you've got the 2 main subtypes, which are inflatable or malleable. The inflatable ones can come as a 2-piece, which is the AMS Ambicor. So you use that when you want to try and stay out of the abdomen with a reservoir. Alternatively, the most commonest ones we use are the 3-piece inflatable implants. The malleable ones are, again, the easier ones to put in. You don't have any components such as pumps or reservoirs, and they're quicker and they're cheaper as well. So here is the Coloplast Titan, and you can see here on the left, you've got 2 cylinders connected to a pump, and you've got a reservoir here with a lockout valve, so you don't get fluid going in and out spontaneously. On the right, you can see the pump. You can see that you've got the bulb at the bottom to squeeze to get the fluid from the reservoir into the cylinders. And then you've got this little nib over here that you press to deflate the implant once you've used it. So this is the same principle. This is an AMS 700. And again, it's been coated with inhibizone over here, which is why it's a bit of a yellow color. Same principle, but the lockout valve is in the pump rather than near the reservoir. The cylinders on this one are a little bit softer as well. And if you've got people who've got either small length or narrow girth, the CXR version is very good for that because it's softer cylinders. The 2-piece one on the left here is the Ambicor. So here you can see that the reservoir is in the back of the cylinders and you don't need to worry about putting in a reservoir. And then the malleable one, you just cut it to size according to how big your penis is and you insert it. Now, one of the key things that we advocate is that these men should have pre-operative counselling. You do need to counsel them to make sure they know what their expectations are. And you first of all show them all of the implants and make sure that they know that it's an end-stage surgical procedure. Make sure that they've failed all other therapies. You know, we often have, patients who haven't been offered injections, but they do very well on injections and don't need surgery. But also expectations. You need to tell them that, look, this won't be like your normal penis when you used to get an erection. This will be, giving you girth and rigidity, but not that extra length. You also want to check that they don't have any hernias or any major pelvic surgery. You want to check that they've got good use of their fingers so they can inflate, deflate the bulb and the pump. And if they've got Peyronie's disease, you need to, plan ahead because obviously it will mean they've got a curvature sometimes once the implant is in, and then you might need to do some additional maneuvers to straighten the penis at the end. So once you know that they've got reasonable expectations, you can hopefully give them a sample pump to practice with. You need to tell them that, they still orgasm, they'll still ejaculate unless they've had their prostate out. But, it's important to have this counselling session with them. It does reduce the number of complaints and dissatisfied patients in the long term. So the surgery itself. Now, Widdy was with us for a while, and he's obviously seen a few of these, but he will remember that we do a 10-minute scrub. So you do a Betadine scrub, 10 minutes. Everyone wears masks. You try and reduce the traffic coming in and out of the theatre suite. You drape them up. You use gowns and drapes which are reinforced, so you don't get any bacteria coming from staff members onto the operating field. But generally, you'd expect an infection rate of between 1 to 3%. In high volume centres, it should be less than 2%. Infection rates go up if you've got additional problems like diabetes or renal transplants or immunosuppression, but generally you should be quoting between 1 and 3%. Here's a technique from Francois Ede, where he basically uses what we call a no-touch technique, whereby the implant doesn't come into contact with any of the skin, and you can see that his infection rate has reduced even more by using that technique. But it is a bit more time-consuming and a little bit more difficult, especially when you've got revision implants. So you can see everything here is draped up, and you don't come into contact with the skin. And then you can see over here, the infection risk for these patients is very low, less than 0.5%. So what about the antibiotic use? Which ones should you be using? Well, these are the most commonest organisms that are found. So you can see that they're, staph or enterococcus. And so you need to make sure that you've got antibiotics which will essentially contain those types of bacteria. So here you can see this is an AMS implant without any inhibisone because it looks white, but then you can coat it with rifampicin and minocycline. And once you've got antibiotic impregnated implants, your infection risk does go down. You can see that there is antibiotic coated. With the Coloplast ones, they come with a hydrophilic coating. So what we tend to do there is we make a mixture of rifampicin and gentamicin in a bowl. So once the implant comes out of the packet, we soak it straight in to that antibiotic preparation, and it will adhere to that hydrophilic coating. So you can either use rifampicin, gentamicin, or you can use vancomycin. I can see this is the one that's coated, and it's got a yellow coloration again. The AUA guidelines, well, they also recommend vancomycin and cephalosporin, but again, it depends on your own local antibiotic policy as well. What about post-operatively? Well, I tend to give them 7 days antibiotics. I give them 2 weeks if it's revision surgery, but you can see over here that over 90% of surgeons will give some antibiotics after the surgery. I think it might be just for reassurance, but I mean, who's going to start taking a risk in not giving them antibiotics? What about the surgery itself? Well, first of all, you need the right equipment, and you can see over here that you need these dilators. These are Brooks dilators. This is your furlough to push the implant in. These are crimpers that you use just with AMS ones. You need enough clips, etc. And here's your implant trolley. And you can see over here that you need these shods on the clip so you don't damage the tubing, some top-up syringes. Here's an accessory kit on the left, which comes with the implant kit as well. So that's the needles and the shods, etc. The dilators, well, I tend to use these Brooks dilators. They come a little bit angled. They've got an olive tip, so it's less traumatic. Don't start from a very narrow one. I normally start from a number 9 and gently dilate up and down the corpora. If you then encounter some fibrosis or difficult dilatation, you might want to use these Rosello dilators, but these dilators are very rough and can cause a lot of damage. You can also use Hagar dilators. These are quite useful if you need to redilate a tract. Here's a furlough where you just push the implant in and the needle through here, and that way that it comes out in the right position in the mid glands. You can change the size of the implant. So you can see here, this is the Coloplast implant. They only come in standard size of 16, 18, 20, but you can use these rear tips to put on the end of them to extend it if you need to. So the approach that I tend to use is a penoscrotal approach. In the States, they tend to use infrapubic, where you just make an incision just below the penoscrotal junction, and then you expose the corpora. So you can see over here, you've got a Scott retractor and some hooks. You then expose the corpora, you find the urethra, and here on the left, you can see that the urethra is pushed out the way. You've got some stay sutures, and I've just drawn a line where the corpora is, and that's where you're going to make your corporotomy. So you open that up with some diathermy, and then you can see here on the right that you see the Brooks dilator going up, and then it goes down, and you dilate sequentially. Always push towards the lateral side, so you don't go through the urethra, because if you do have a urethral injury, you need to generally abandon the operation. You can do your checks. So you can see here, this is the proximal dilatation that you want to just check that it's equal. So you've got the Brooks dilators here, which are equal on both sides. And then you do the same distally and make sure there's no crossover. So you can sometimes inadvertently cross over from one side to the other when you're dilating, which means that the implant cylinder will cross over as well. So you want to try and avoid that. Here's the pump that's going to be put into a Dartos space over here. So I'm just going to demonstrate here. So you put a Langerbeck in, make a space in the scrotum, and you put the pump in to that Dartos pouch here on the left. And then I'll put a purse string in there just to keep it held in place. On the right, you can see that we've got a Coloplast Reservoir, and we're putting it in blindly into the superficial ring, into the space of Retzius, and that's where it's going to lie. So you can see over here, that's what we tend to use. So make sure you empty the bladder, and then you poke through the fascia transversalis, and then you put the reservoir in. The AMS implants are coming 12, 15, 18. And again, you've got the rear tips here that you can extend. So if you've got a 15 implant, but you need to measure it to 16, you put a 1 centimeter rear tip at the end of the implant. Just remember that when you do look at the ends of the two implants, it's Coloplast and AMS, look at where the exit tubing comes out, because it will depend on how much rear tip you want to use, whether you want to use a smaller implant and a longer rear tip to make sure the exit tubing comes out quite nicely. See here that if you see the exit tubing comes out 3 centimeters, you put on a 3 centimeter rear tip, the exit tubing will come out at 6. So you want to just be careful that you don't end up burying too much tubing. Here's the reservoir. So this is a cloverleaf reservoir from Coloplast, and this is the flat reservoir from, which is called a conceal from AMS, or the spherical reservoir, which they normally hold about 65 mils. This one holds 75 or 125. And the conventional place to put the reservoir is here in the space of Retzius. However, if you've had major pelvic surgery or cystectomy, you want to keep out the abdomen, you can put it just behind the rectus muscle over here. That's called ectopic reservoir placement, and because of the lockout valve, we can do that more so now. So you can see here, we go in through the same incision. So there's a penoscrotal incision. We'll make a little pop into the fascia transversalis, and you can see over here the nasal speculum going into space of Retzius. And then what we do is just push down the reservoir into that space, and then you can do all of the surgery through one penoscrotal incision. Complications, well, I'm just going to go over a few of them. So over here, when you're measuring up after you've dilated, that it should be like an American football goal. So the two dilators should be at the same level. If, however, you've perforated, you can see over here, you've obviously perforated on the left-hand side, these will be at different levels, okay? So you've perforated the proximal crura, and then you're going to have to try and salvage something. So you can see this is how proximal perforation occurs, that the dilator's gone straight through. So either you can try and redilate into the correct area here. If you still fail, because if it's a big perforation, you keep going down the wrong way. So what you tend to do is, these days, we do what we call a hitch stitch over here. So we put a stitch into the rear tip, and we put the implant in, inflate it, and just tie this so it kind of supports that rear tip and the implant, so it won't erode. What about urethral injury? Well, generally, we tend to put a catheter in if you've injured the urethra, leave it for 2 weeks, and you need to do another operation in 3 months' time. The more difficult ones are where it's really fibrotic, and it can be fibrotic due to Peyronie's or Priorism, because they've had a previous implant and got infected. But here you need to be very careful, because if you try and dilate too hard, you may end up perforating, you get crossover, and cause quite a lot of urethral damage. So there are some tricks. So here you can see you can use the Rosello dilator or corporatomes, whereby you're just basically filing the corpora. The other thing is you can use some very sharp scissors and open up to try and dilate. Or sometimes where it's really fibrotic, you've got to make a second incision. So you deglove, make a second incision, always circumcise. You can deglove like this, and then try and get the implant in. The other difficult fibrotic ones, you might need to just excise the fibrosis. So you can excise it sharply with diathermy to make some space, and you can get it in and then close up. So, you can generally get implants in most people. With the Peyronie's patients, you can put the implant in. When you test it on table, they may still have a bit of curvature. So there are some maneuvers that you can do. One of them is obviously you can do manual modeling of the implant. So you inflate it, put some shods on so you don't damage the mechanism, and you bend it opposite way to the curvature. You can also put in some relaxing incisions, or you can put in some plication incisions on the other side. If the residual curvature is about 30 degrees, you probably don't need to do anything, because by cycling the implant for 6 months, the penis will probably straighten. The other ones which are difficult are the Prypism patients, because they've got some severe fibrosis. If you've got an acute Prypism which hasn't gone down despite using shunts or phenylephrine or whatever, you can put a malleable implant in about 2 weeks, but you downsize it. Don't stick it in right up to the tip of the glands. Downsize it, because the penis will shrink a bit, so you get less chance of erosion. So that's with Prypism. But if you've got a late Prypism, so you're doing it 6 months later, it is like wood inside. So you need to then use those tricks to help get over the fibrosis. Sometimes, due to anatomical reasons or wherever you've positioned it, people complain that they can feel the tips. So here on the ventral side, he feels the tips. So what you can do here is reposition the tips more dorsally so they don't feel that. So you just do a circumcoronal incision and you put the tips a bit more dorsally. This complication here is what we call an S-shaped deformity. So here the implant, it's an MRI scan, has been put in and the cylinders are too long. What you find here is the implant won't work. So you need to replace that with a slightly smaller implant. So either they're oversized or they're not sitting in the crura properly, but you just need to revise and put in an implant which is better. So I just wanted to give you an overview of the surgery and some of the complications from implants, to give you an overview there. I'm quite happy to take some questions at the end, Widdy, if that's what you're planning. But that's the end of my lecture. Thank you very much.
Okay, thank you for the explanation for the penile prosthesis, Dr. Asif Munir. So I think we can discuss about this topic at the last session. So after this, we can hear about how to set up the men's health center. We already have the Dr. Faisal Yafi here. So Dr. Faisal, can you hear me?
I can. Can you hear me, Weedy?
Yeah, I can hear you. Okay, how are you?
Good. How are you? Good morning.
Yeah. So I think at US, I think you at your place is like 6 a.m. right?
Correct. Yeah.
Okay. So sorry to disturb you. Okay. Yeah. So I think we can proceed because I think we can. I can explain your CV before. So Dr. Faisal Yafi, the current position is at the University of California, Irvine as the assistant professor, and also the chief of division of men's health and reconstructive urology, and also the director of men's health, and also the director of the UCI Urology Newport Beach. And Dr. Faisal Yafi finished the residency at McGill University Health Center at the Department of Surgery and Division of Urology at the 2014. And at the 2016, finished the fellow of the Division of Andrology at the Tulane University School of Medicine, New Orleans, Los Angeles. So I think, Dr. Faisal Yafi, the time is yours. You can share your screen. Not yet, because okay, I can see your screen now.
Okay, wonderful.
Okay.
All right, wonderful. Well, thank you for the introduction, and thank you to Jump 2020, Dr. Widya, Dr. Wahudi, and my friend Dr. Atmoko for the invitation to speak about how to set up a men's health center. So I've actually not given this talk to other physicians in the past. I've given it to non-physicians, so bear with me. And this is the first time I'm giving this talk, and hopefully it's useful. So I try to gear it towards really the ins and outs of how to get a comprehensive men's health center, and what are the struggles and what are the things that you have to keep in mind if you're trying to do this. So on the left here is our hospital in Orange County, but you can see on the right is our actual medical center. They're located in two different places. The hospital is in Orange, and the men's health center is in Newport Beach, a slightly more affluent area with the older population of men who need more men's health issues. For those of you who don't really know where Orange County is, this is a map of the US on the left. The red is California. And then if you look on the right, this is Southern California. Most of you will recognize on the bottom Los Angeles and San Diego. So we're basically halfway between Los Angeles and San Diego. I always like to show these pictures. On the left is Newport Beach, where the offices are. So a lot of very, very wealthy men with very bad erectile dysfunction. And on the right is Laguna Beach, one of the nicer beaches in the United States. So here are my disclosures. None of them are really related to the discussion today. So we're fortunate at UCI that for the past 4 years, I've been doing a men's health and prosthetic courses. And during these years, we've had a lot of physicians come from international locations. And over the years, we've been lucky to have Dr. Gampo Alam Erdem and Dr. Widya Atmoko, as you can see here on the photos, come and join us at our courses. And it's been absolutely wonderful. Dr. Atmoko also came and joined us in the clinic. So it's been absolutely wonderful having him here. So getting to my topic. So when you talk about men's health center, what are the things that are needed for you to have a good men's health center? So one, you need the space. You also need the team. You need the specialties that are covered in your center. So you need urological services, but you also need other services there. You also have to figure out what kind of services, what kind of procedures, what kind of interventions you're able to offer in your center, but also the center procedures that you might need to send out somewhere different to get them done. You also might want to consider having your own pharmacy in your men's health center. And finally, how do you get the patients? So how do you patient acquisition, and how do you market for your clinic to get patients to come and see you? So when we talk about space, location is very important. As I mentioned earlier, our hospital is in a different location from where our men's health center is. A lot of the men's health center procedures and interventions and conditions are geared towards older men. So you want to make sure that you're in a location. For example, you don't want to be close to a campus of a university because you're not going to get that many patients. So you want to try to be more in a location where you think you're going to capture more patients. When you talk about a physical space for a men's health center, the main things that you want to think about are exam rooms. Do you have procedure rooms? What are the capabilities of what you're going to do? And then alternatively, you can have a virtual men's health center. And now, especially in the United States, with COVID, we've turned a lot of our patient visits into audiovisual or virtual visits. So you want to make sure that you have the proper audiovisual setup like we have right now. But there are obviously some limitations to having a virtual clinic. When we look at a clinic, on the left is our men's health center waiting room. So you see, you want to make sure you have a comfortable waiting room for patients to feel comfortable. Often men coming to a men's health center are a little bit uncomfortable. They're embarrassed with their conditions. They're reluctant to come. But we also know that men's health is probably, when we talk about ED and BPH, the most common reasons a man will go to a physician, sometimes before other things such as cancer. So it's important that we make the environment comfortable. As you can see in the back, we have a screen. We found that a screen is very useful. So the screen runs all the procedures that we do, but it also runs the names of the physicians and their specialties, but it also runs the clinical trials and the studies that we're doing. And we'll often get patients who come into the room already asking to be enrolled in a study because they saw something about it on the screen. On the right is a little bit more of an extreme case of a men's health waiting room. This is called the New York Man Cave. It's in New York. And again, here, the idea is the same. You're creating this safe environment for men coming for PSA screenings and things of that nature. And you can see here a lot of sports memorabilia, some American football and hockey. I don't think sports that are very popular in Indonesia, but you can cater this to whichever population of patients that you're getting. We like collaborative workstations. So the way our clinic is shaped in a U shape, and there are intersecting in the middle 2 workstations, and that makes the workflow easier. It allows you to run back and forth the rooms, but it allows you to communicate much faster with your nurses, with your residents, with your research assistants, your medical assistants, etc. So that is what we found to be a more useful setup than a physician sitting in our office and everybody else somewhere else, and you have to, go back and forth to try to relay instructions. When we talk about procedure rooms, patient rooms, we like multi-purpose patient rooms. As you can see here, this is a bed that is adjustable, so we can do vasectomies on this bed, we can do injections on this bed, but we can also examine patients of all ages. A room also includes a screen. The added advantage of the screen, for example, Dr. Munir is talking about penile implants. When I have a patient who is considering a penile implant, I'll run some videos on the screen discussing the penile implant, the various devices, but also there is a patient testimonial on it. And so these are little things that can save you time when you go into the room afterwards with a patient. The computer setup also allows you to connect the computer to the screen. So if you have a patient, you're trying to show a CT scan or you're showing some imaging, you can move the image from your computer up to the screen. You always have to make sure you have extra seating. A lot of the men's health issues are couple-related issues. So you want to make sure that there is a place for the spouse or the partner to be there so that they can partake in the care. This is very important for me for patients with ED or infertility, for example, where I like the partner to be there because the patient will only keep this much information from the call or from the discussion, and then the partner will have a lot of questions when they go home. Procedure rooms are essential for a men's health center. So you want to have a procedure room that allows you a lot of flexibility in what you can do. You can see here our cysto tower. You can see the procedure room that allows us, you can't really see it here, but it has stirrups. So we're able to do cystoscopies. We do our urolifts, our resumes, and soon our ITINs on this bed. So these are all multifunctional purpose rooms. We do our penile duplexes in there. We do injections. This is a urology clinic, so clearly there will be men who have urinary issues. So you want to make sure that there should be a bathroom pretty close to your procedure rooms. Men will often need to run to pee after the procedure or just before the procedure. You want to have medication and utility rooms. On the left is our pharmacy for controlled substances. And you can see there's a lock on it, and this allows us to leave controlled substances such as testosterone and pain medication. We have our cystoscopic setup here that allows us to re-sterilize, at least store our scopes. And on the right is our centrifuge as well as our microscope for when we dip urine and we're trying to look at it in the microscope. So all of these things are things that you need to consider when you're setting up your center. And then sterile processing is another room that is essential. We do all the processing of our scopes and our equipment in-house. So we have a person that is dedicated every day. So what we do is we have a team of medical assistants. One of the medical assistants every day is trained to sterilize instruments. So that allows us to be more efficient and not have to rely on transport back and forth to the hospital. As I mentioned, our center is in a different location from the hospital. So if we had to send to the hospital every time we wanted to sterilize an instrument, it would be a large waste of time and would not make us very efficient. Now, you can also have a virtual space when you want to do men's health, so you can talk to your patients on the phone or by video. You want a private space. So if you can see here, there's a camera mounted on the computer in the corner. This is one of my partners who was talking to patients about kidney stones, and he's talking to them there. Now, while you could do potentially this for patients with kidney stones, if you're talking to a man about erectile dysfunction or Peyronie's or curved penis, something of that nature, it's probably not a good idea to be sitting in the middle of a hallway where people are going to be walking back and forth behind you. That would make it very uncomfortable for the patient. So for my purposes, for my Zoom visits, I like to sit alone in a private room and talk to the patients. And this is basically the room where I'm sitting right now. You want to make sure that you have a strong internet connection. You don't want your phone calls to fall, because especially if you're scheduled pretty tight, if your connection is not very good, you're going to end up losing patients and getting frustrated. You want to make sure they have a high resolution camera so that the patient can see you well. I often have patients who are traveling from across the country to come and see us for particularly for instances like a penile implant or a malfunctioning penile implant. And you can get these patients to expose themselves on the camera and they'll show you how they're using the device. So that saves you on your first visit at least. And you want to make sure you have an easy interface. So we're using Zoom right now. You want to make sure that if you're using an interface with the patients, that it's easy. It's obviously preferable that you have an interface where the patient can access it through their phone. That way they're not necessarily on their computer to be able to access. But there are limitations to virtual medicine. There is no physical exam possible. And that patient connection that you get by sitting in front of a patient is lost. So obviously some certain limitations to that. When we talk about the team for a men's health clinic, so you want a physician. So in our practice, the physician, myself, I see new patients, I see surgical patients, I see patients who are getting procedures. You can have a physician extender. I don't know how the situation is in Indonesia with regards to physician extenders, but these can help you with follow-ups, with post-ups, things that would take a lot of your time that you don't necessarily need to see. We have a nurse who's responsible for injections, for patient care, wound care, things of that nature. Medical assistants are important because they're going to room your patients, they're going to discharge your patients, they do vitals, but also, like I said earlier, they process and sterilize our instruments. You want someone in the front desk who has a big smile on their face. Patients are uncomfortable when they're coming in for men's health issues, so they're going to check in and check out your patients and schedule them. We do a lot of clinical trials here, so we have quite a revolving door of research students and coordinators here who are responsible for study enrollment of our patients. And you might potentially consider having an ultrasonographer, especially if you're doing a lot of ED and Peyronie's and you need to do duplexes, or you're doing infertility and you're doing a fair amount of scrotal ultrasounds. So an ultrasonographer might be useful. This obviously is something everybody knows. Make your nurses happy and your life is going to be happy in the practice. And we have a pretty large team, and overall they seem to be happy. Now, when we talk about the urology specialties that you want to include in a men's health center, you definitely want to include sexual medicine. You can include oncology, particularly prostate cancer. You definitely want to include PSA screening. You need to include voiding dysfunction. A lot of patients who have ED or low T are also going to have urinary issues. You might consider including male infertility as well. Whether you want it or not, you're going to have a lot of general urology, and you can include stones as well if you have the capacity in your center. When we talk about sexual medicine, the prevalent conditions that you're going to see, you're going to have patients with erectile dysfunctions, patients with Peyronie's, low T, and all kinds of ejaculatory and orgasmic dysfunction. So these are the sexual medicine conditions that you want to be able to address. When we talk about ED, some of these things were obviously covered in the previous lecture, but you want to be able to offer a penile duplex Doppler ultrasound, because this will often be the only way that you're able to objectively diagnose the cause of the ED. I also use it a lot in younger patients who have psychogenic ED, because I find that showing them in a more objective fashion that they have normal erectile function helps them overcome their psychological issues. You want to be able to offer PDE5 inhibitors, intracavernosal injections. You want to also be able to do teaching for intracavernosal injections in the clinic, discuss vacuum erection devices. We use a fair amount of constriction rings with patients. You want to be able to discuss, do training, show all the different penile implants. You want to make sure you have a space. I have a drawer in my office that has all the different penile implants, so we're able to show them to the patients. We have them play around with the different pumps for them to decide which implant they like the most. diagnosed. We only started recently doing low intensity shockwave therapy as well for ED, and this is something that you can add to your armamentarium in the office. And I highlighted in red because it's incredibly important. You have to have an access to behavioral, couple, and sex therapy. This is something that is often left out of men's health clinics, but this is probably as important as everything else on the slides. You want to make sure you have access to that, and I'll discuss how you can do that. This is an example of our ultrasound machine for our duplexes, and an example of a duplex on the right. You want to make sure you have a linear probe, not a circular probe for the duplexes. And we can talk in more details if you'd like about the frequency of the device that you want to use. But essentially, you need to be able to do this in the clinic with an intracavernosal injection. We just started recently using a low intensity shockwave. Like I said, we're using the Eurogold 100, which is a parabolic unfocused shockwave device where we do 3,600 shocks to the penis, dorsally, ventrally, on both laterally, as well as into the crus. And we can also discuss that. So it's about 6 treatments per patient. And currently we're doing the treatments every week. And that's an additional option that you can offer. You want to make sure you don't offer acoustic ballistic therapy, which is very prevalent, at least in the United States. So in the United States, acoustic ballistic therapy, which is not real shockwave therapy, does not require a physician to do it. So you can go to a hairdresser and get your penis shocked. So you want to, be careful. So if you're going to offer something in your practice, you want to make sure that you offer something that is of high quality and that has some evidence behind it. The best evidence for shockwave therapy comes from Europe, where they've been the pioneers of this, and there are some really good papers. There's a really good paper in the sexual medicine reviews by Professor Prost that you can look at that really reviews everything you need to know about shockwave therapy. Then we go to Peyronie's disease. You want to also be able to, again, to offer an ultrasound. You have to have this instrument that you see here. It's called the goniometer. It's an instrument that allows you to measure curvature. You can either buy those disposable goniometers. I prefer the disposable goniometers. Even if a lot of people use the metal ones, I just don't like the idea of using one, even if you're washing it with alcohol and then putting it on different penises. So in general, I prefer these disposable ones. I'm not saving the planet doing this, but you have the choice of doing either one of the two. Then we talk about injection therapy. We have collagenase. I know collagenase has been mostly withdrawn internationally. We still have it, but you can also do interferon, you can do verapamil, and you have to be able to offer different surgical options for Peyronie's. Then we move to testosterone or low T. So you want to be able to have access to labs. We don't have a lab in our clinic per se. We have a lab across the street. But if you have the capacity of having a lab, that also makes the experience for the patients easier, and you can draw the blood in the room. So you want to be able to draw testosterone in older patients or patients who are predisposed. You want to be able to also draw free testosterone. And in dependent populations, you're going to want to require check estrogen levels, LH and FSH, particularly in your infertile fertility patients. In the US, we often check LH because often insurance providers will request a cause for the low testosterone, so LH might be useful. If you have a patient in whom there is some discrepancy, or you're not really sure why their testosterone is low, or why they have ED, or why they're infertile, prolactin is often useful, and we usually diagnose 1 or 2 pituitary microprolactinomas every year. And then you want to be able to check TSH, which is often a easily missed hormone that would explain a lot of patient symptoms. When you talk about testosterone replacement, we offer IM and subcutaneous injections. We offer testosterone pellets in the clinic. These are very easy to do under local anesthesia. They are not necessarily branded. You can get these now compounded by compounding pharmacies, and they're very useful, particularly for patients who don't like to do anything themselves. Topical testosterone in the US, oral testosterone just got FDA approval this year and is commercially available. So there's various ways, but you also want to also be able to offer other hormone replacement therapies for the infertile, for the patients who care about fertility. You want to be able to offer clomiphene citrate, anastrozole if you're trying to bring down estrogen, but also HCG in patients in certain populations of patients. Then we also offer oncology services in our office. Like I said, this is not absolutely necessary to a men's health clinic, but you have to be at least able to screen for prostate cancer with a PSA. We also offer MRIs, radiology centers across the street, and we also offer trust biopsies in our office and fusion biopsies. You can see here, this is an Artemis biopsy machine where you can do a 3D fusion biopsy for prostate cancer. You can screen for urothelial cancers with cystos and urine assessments. And we're fortunate that we also do a fair amount of ultrasounds or percutaneous renal biopsies for kidney tumors. But again, this is going a little bit outside of the realm of men's health. And then when we talk about avoiding dysfunction in BPH, even if you go into a men's health center hoping to be just a sexual medicine doctor, there's no way out of BPH. You're going to have a lot of BPH patients. You're going to have to be able to do uroflowmetries to assess flow strength, be able to do bladder ultrasounds to see post-void residuals, be able to offer cystoscopy. We also have a video urodynamic study room. All our patients who are getting, or the majority of our patients who are getting surgery for their prostate will get urodynamic assessments before surgery. Patients who are getting in-office procedures don't usually get those unless certain circumstances, but we also offer a Urolift and Resume in the office. We're soon potentially going to start offering also iTind. We also offer all other options for BPH, but these, the TURP, PVP, robotic prostates, prostate artery embolizations, these are obviously done in the operating room, but are offered, and we have forms and we have instructional and reading material on all of these for the patients. It should be also able to offer incontinence surgeries, whether that's male slings or urinary sphincters, or in certain instances now we do something called a mini jupette, which is a sling that we put at the time of the implant. These are all things that you should be able to offer. Urolift and Resume, like I said, we do them in the office. Most places in the United States do these in a surgery center, but we do them in the office. We've been able to do these in a cysto bed that you saw with stirrups. We give the patient local anesthesia with basically intraurethral lidocaine jelly. We give them anxiolytic and antibiotic and a pain med an hour before the procedure, and we do a pudendal block. And we've been able to do these in just about everybody, and it works pretty well, and patients are able to go home immediately after. You also have the choice of including fertility in your practice. Whether you do your semen analysis in-house or not is an option. Semen analysis can be pretty pricey if you want to have a lab in your clinic. If you're able to afford that, then it's great. We decided to outsource our semen analysis to a place that we trust. You can do sperm retrievals, so you can do TSAS and PSAS in the clinic per se. Obviously, if you're going to do a microtesty or a vasectomy reversal or varicocele, you're going to need to have access to a microscope. And if you're going to do a microtesty, you have to be able to have an embryologist with you and potentially a free sperm. So we have a really nice setup where the fertility center is just in the building next to us. So especially if you're going to do fresh specimens, it's really important that you have a center that's close to you and you don't have to travel halfway through the city to go somewhere to do sperm retrievals. So we're lucky that we're able to find a place very close to us for that purpose. Nobody likes to see the prostatitis, chronic pelvic pain, or arcalgia, but these are patients that need to be seen, and they are going to be seen in the men's health center. So you have to, you're going to get the patients who have prostatitis who are on antibiotics or been continuously on antibiotics for, a year or so. So we try to get those patients off antibiotics because often prostatitis is inflammatory and it's often related to either chronic pelvic floor dysfunction or inflammation. We do a lot of physical therapy. Again, you can see behavioral therapy and physical therapy are the only things highlighted in red in my talk because of the importance of it. Whether you have a physical therapist in your office or you outsource this and send patients out are important. We do a lot of pudendal block, we do a lot of referrals to pain service, but we also do for arcalgia a lot of cord blocks, spermatic cord blocks in the clinic. And then we also perform microdenervation on patients who respond to the cord block. So these are all extra things that you can do in your practice for patients who will come with these conditions. When we talk about non-urological services, as you can see here on the right, this is the sign at the bottom of our building. So we're on the second floor with urology and men's health services. On the ground floor is sleep medicine and behavioral health. So the easy and close access to these things make it easier for us. So physical therapy, you should either have physical therapy in your center or have a good access to physical therapists. Our behavioral, sex, and couple therapists are inside the same building as us, which makes it easier for communication and collaboration. We have a sleep center, and I'll tell you how we refer patients there. We do a lot of preventative cardiology. You have to have access to endocrinology. We do a lot of nutrition referrals. So the way we set up nutrition, we thought about having a dietitian in the clinic. Space is always limited and doctors want more rooms. I've never heard a doctor who said he has enough or she has enough rooms for their practice. So we tried having a dietitian in the office, and we felt that the dietitian visits were very long and taking a lot of space in our office. So what we do now is we have virtual dietitians, and dietitians don't need to do a physical exam. So that makes it easier. And again, this is the first floor where the sleep and behavioral health are. And if you go up the stairs, on the second floor is urology and men's health services. So we offer a lot of questionnaires to our patients, and this allows us to, for research purposes, but also allows us to refer patients as needed. So in terms of urology questionnaires for the Men's Health Center, we use the SHIM score, we use the IPSS and quality of life for urination, we use the PDQ for Peyronie's, and we screen with the ADAM questionnaire, although I can't say that there's a lot of utility to the ADAM questionnaire because just about every man will score on it as having as positive. But we also use a lot of non-urological questionnaires. So we give those questionnaires to patients ahead of time. So they are sent these questionnaires before they come to the clinic, so they have time to fill them because they take a while. So they fill the PHQ-9, which is a questionnaire for depression, the GAD, which is a questionnaire for anxiety, the Stop Bank questionnaire, which is a screening tool for obstructive sleep apnea. They fill the ISI, which is a questionnaire for insomnia. And we have an extensive dietary questionnaires that all patients have to fill at the time of the visit. So how do we automatically refer patients? So for cardiology, basically we ask patients about their exercise tolerance, particularly if you have young men in their 30s or 40s who have ED or low T, and for example, you do a duplex and the duplex is normal. These are potentially patients that you want to consider referring to cardiology. Endocrinology, patients with prolactin or thyroid abnormalities. The sleep center, any patients who scores on the Stop Bank or the insomnia questionnaires are offered automatically referrals to the sleep center. We also check patients who have nocturia. Nocturnal polyuria and obstructive sleep apnea are often underdiagnosed, so these patients will be assessed. For behavioral therapy, again, based on questionnaires, if they score high on the PHQ-9 or the anxiety questionnaires, patients who have couple issues or psychogenic sexual dysfunction. And then for physical therapy, we use it a lot for patients with chronic pelvic floor dysfunction or chronic pelvic pain syndrome, as well as some patients with scrotal pain where we think that the etiology is more in the groin than it is in the testicles themselves. We, with regards to nutrition, like I said, we have a very extensive questionnaire. We have referrals to dietitians, which are virtual. We do a weight loss management center at UCI, so we're able to send the patients there. But we also do a lot of gut microbiome testing. This is more on the research side, but we found that the gut microbiomes in the US, there's a couple of companies where you can test your gut microbiome by giving a stool sample, and they'll give you an idea about the bacteria in your gut, and that will allow you to sometimes give some recommendations on probiotics and things of that nature. Obviously, these are not things that the urologist has to do, but if you have a nutritionist, they can help you with that. And this is, for example, just an example of a study that we've done in showing that patients with Peyronie's tend to have a difference in their gut microbiome compared to non-Peyronie's patients. Now, if you have a pharmacy in your clinic, that's helpful because that will allow you to dispense medications immediately to patients and make their experience easier. There are a lot of limitations to having a pharmacy, especially if you're going to use controlled substances like testosterone. But there are a lot of advantages. One, for patient ease, but also it can be a source of income for the clinic. So you can offer testosterone, other hormones, prostate cancer medications, antibiotics, intracavernosal injections, phenylephrine, PDE5 inhibitors, but also supplements. We use a lot of quercetin, a herbal supplement for chronic pelvic floor, but also supplements for fertility, etc. So these are optional that you can also consider having in your practice. And then you can have a small urology store. You can offer things like the stretching devices. The top right is the stretching device that we use. It's called the Restore X device that was developed at the Mayo Clinic. It's a really nice device. It's very expensive though, but you can use other stretching devices as well. I don't use a lot of vacuum erection devices, but there are something that you can potentially offer through the clinic, and then you can use various types of constriction rings, the ones on the left or the ones on the right that I prefer that are adjustable for the patient. But all of these are things that you can offer through your practice. And how do you get your patients? So you want to try to set yourself as a center of excellence. The easiest way is to do this through your practice, through your institution. So you agree within your institution, there's only 1 or 2 people who are going to do, for example, men's health or prosthetic urology, and then everything gets funneled into these people. So this is how you capture from your own department. You want to make sure you get internal referrals from within your institution, so advertise yourself and offer what your services are. You want to make sure you talk to the internal medicine specialists and the family doctors in your institution, but also in the community. You can do core marketing with industry, so you can work with one of the the prosthetics or BPH companies to try to get patients to them. But right now, today, in our world, most patients today are through direct-to-consumer marketing. So you can do websites, you can do radio, you can do TV, you can do billboards, and that's how often a lot of patients with mental health issues are going to come. So, for example, we send a pamphlet like this for just about every one of our specialties into our area, and we get a lot of patients who come in just because they read these things. We have, websites. Most of our physicians have websites to our institution. You can see Faisal Yafi MD, UCIMensHealth.com. You obviously don't have to handle the content. You can have someone handle the content for you, and patients can go there and get all the information they need. This is, for example, an Instagram page, UCI Men's Health Center, and you can see there's content-driven material all the time that is direct to consumers with information on how to schedule appointments. And these are all things that you can do on your end to try to get patients. So in conclusion, the Men's Health Center can be set up in many different ways. If you want to do a comprehensive men's health center, you should also be able to offer non-neurological services. These can be either on-site or off-site or virtual. Disease prevention is at the end the optimal goal, so you have to try to see what you can do to make patients avoid having conditions in the future. Procedures can be offered in the clinic, and you really can do just about anything. We now do circumcisions, hydroseals, and now we've also started doing a few penile applications in the office with local anesthesia. So these are a lot of things that you can add to your practice to make your clinic more efficient and decrease the burden on the operating room. And then questionnaires are essential for appropriate patient screening. And again, thank you for your attention.
Okay, thank you, Dr. Faisal Yafi, for your beautiful explanation. It's so amazing center that you have. I think you have all of the equipment for the urology, I think. Okay, so I think we can proceed to our discussion. So I think we have about 20 questions. Okay, so I think we can discuss together. So for the first question, I think it focused on the ESWT. Dr. Ponco, you have so many questions. Okay, I think because ESWT is now getting popular in Indonesia. So from the first question, maybe for Dr. Ponco, but for Dr. Faisal or Dr. Asif, if you want to answer together, you can give your answer. So the first question is about the ESWT. So is there any consensus agreement on ESWT protocol on interval between the treatment session and how much the shockwave is being delivered, and what is the best energy delivery system? And besides that, how about the combination with the PDE5 inhibitors? And do you usually use the ESWT combined with the PDE5 in the first place, or maybe do you usually use the PDE5 first if it is not active or if it is not to work? You can combine with the PDE5, and which kind of the PDE5 inhibitor that you usually use for the patient with combination with the ESWT?
So I can answer from the U.S. perspective, and then Dr. Munir can answer from the European perspective. From the U.S. perspective, there is no consensus whatsoever. So 95, if not 99% of the shockwave that is being offered in the U.S. is not appropriate. So it's basically the acoustic ballistic therapy, which doesn't work. In terms of the shockwave therapy, there's no consensus at all. So we use a flux density of, we start with 0.13 on most patients, and at a frequency of 4, and we deliver 3,600 shocks to the patient. We do it 6 times, but again, we're part of a prospective study that we're collecting data. So I think in the United States now we're still at a point where we're just still collecting data and we're trying to understand it a little bit better. We offer PDE5 inhibitors from the get-go for these patients, and we offer them. I offer daily, low-dose Cialis usually to these patients. In terms of which patients are candidates for it, it's really hard to tell. So basically, it's patients with mild to mild moderate ED who are trying to get from mild to less mild ED. Basically, I don't think it has a role in patients with severe or moderately severe ED. And I tell patients basically, if you consider your erections in 4, this is really soft, kind of soft, minimal soft, and hard. You're gonna just go 1 up. You're not going to go from here to here with a shockwave. But it's really hard to counsel patients, at least on our end here, because our experience is still small and the data is not available for us to really counsel them well. But Europe, and I'm sure Dr. Munir, they have significantly more experience with shockwave than we do have in the US.
Okay, thank you, Dr. Faisal, for your explanation. So maybe Dr. Asif Munir, do you have the answer, maybe?
Yeah, I mean, the problem with shockwave treatment is that there's so many different machines and protocols and, protocol in terms of sessions and also intensity. When we used to offer it, we used to do 1,500 with the machine that we had. You give them a weekly treatment for 3 weeks, then you take a 3-week break, and then you do 3 weeks again. There's some machines now which they just do 6 weeks in total, one after the other. Others say 12 weeks. But I'd be interested in, with the sort of multi-center trials which are now going on with sort of fixed protocols and fixed machines, as to what the outcomes are. When it comes to patient selection, again, I mean, I think just from the question that was asked, if you've got someone who's going to respond to PD5s, I mean, that is a better option. If you've got someone who's failed PD5s or are no longer as effective, they may be salvaged using low-intensity shockwave treatment. If you've got someone who's failed or who's got contraindications PD5s, again, it may be an option for them. I don't think this is an option for those who need to go into second-line treatment options such as prostaglandins, intracavernosal, or intraurethral medication. I don't think it's appropriate for them. They will probably not get a great response. So you limit it to those who want to get off PD5s or got contraindications. You may want to try it. Also in our protocol, we give them daily tardalafil. So you use it in combination. Again, we don't know what the benefits are. In fact, for a long time, we didn't really know how shockwave treatment worked. But I think, we need better data. I think the original studies weren't great. But we need better data.
Okay, thank you, Dr. Asif Munir. So how about Dr. Poncho? Do you have any experience on giving the ASWT with the PDA5?
Yeah, as Dr. Ayafi and Dr. Munir said that we have to make a selection of the patient first, and the treatment should be started with the first line, the medication, PD5 inhibitors. If the fail, then second line option. Either this is the vacuum American device or injection. But the problem in hello, Dr. Widi, can you hear me?
Yeah, I can hear you, Dr. Poncho.
Okay. But the problem is we have difficulties to getting the injection substance in Indonesia. Since 2015, we cannot find any cover jack anymore in Indonesia. So maybe the ESWT can be one of option for the patient before the patient having the last option. It is the prosthesis penis. If with the patient is getting better with the PD5 inhibitor, and then they continue. If does not respond, and then we can offer the ESWT. Is it combination or not? Usually I use the combination to for the patient.
Okay. So yeah, besides that, maybe I want to ask to the Dr. Faisal, when I visited your clinic, someone talks about the ESWT that maybe in US, you have like a classification with like the ESWT level 1, level 2, level 3. I don't know, but I cannot see from the textbooks. But can you explain us about the classification of the ESWT? Is it dependent on the machine, on the system, on the energy, or maybe is there any criteria? Maybe you tell us.
So it's just a classification of the devices by the FDA, and it's based on the energy delivered and the machine being used. So for example, what we have commonly in the US is called GainsWave, which is what I was talking about, the acoustic ballistic therapy, which is a much lighter energy that is focused. So this does not it has a low classification. So what happens is anybody can use it. You don't need to be a medical provider. So you can go into the mall and you can have a hairdresser, which a lot of hairdressers now are offering it, or a nail salon will be offering it in the back room, right? Whereas if you're actually using shockwave therapy, it becomes the same way as if you're using shockwave therapy for kidney stones, that has a higher level of classification. Then at that point, it has to be provided by a medical provider, whether that's a physician or a physician extender. And then if under the supervision of a physician, you can have a nurse doing it. And so that's basically the main difference. The cost also of the shockwave device tends to be much more significant than the cost of the ballistic or acoustic therapies, which are currently much more available and readily available. The main thing that you have to be careful is advertising, so that we face in the United States, because we can't really advertise for these interventions for erectile dysfunction because they're not FDA cleared for this. So the only clearances we have are for connective tissue repair and for neovascularization or improvement of blood flow. So I don't know. We also in the US, we are allowed to advertise directly to patients with regards to medical care. In a lot of places, you're not allowed to. For example, in Canada, you can advertise medical devices or medications to patients. In the US, you can. But you have to be careful that what you're doing is compliant with approvals. So for Shockwave, for example, we don't advertise for it. We'll say generically we're offering, restorative therapies for ED, but that's about it.
But how about the energy? I mean, do you prefer to use maybe the focus energy or the linear, or maybe like the radial? Is it the same effective or not?
No, so we use the unfocused parabolic therapy because it allows you to offer a larger amount of energy to a larger area. So that's what we use. So the device that we use is called the Uragold 100. It's by a company called MTS. But there, like Dr. Munir said, there's a lot of devices and nobody really knows which is the best device and what are the best settings because there's so much heterogeneity between all the data and all the studies.
Okay, thank you. So I think we cannot conclude that which is the best treatment for the ESW, right? Okay, so I think another interested question. So maybe for Dr. Poncho, how can we diagnose? You said that in your presentation that ESWT is suitable for the ED with the vasculogenic problems. So how can we diagnose the erectile dysfunction with the vasculogenic factor, maybe with the ultrasound or maybe with another examination? How about it?
Yeah, the easiest is using the ultrasound, and we can see the peak flow velocity. And first is from the anamnesis. We can distinguish from the anamnesis whether it's organic or psychogenic. And if this more to psychogenic, and then we will conclude it's not the organic. If the patient is more to organic, we have to distinguish whether this is the vasculogenic, endocrinologic, or neurologic. From the good anamnesis, I think we can have a 70% diagnosis whether this is arteriogenic or neurogenic or endocrinologic. If it's still not sure, then we can do the ultrasound examination. If we are still not sure, then we can do the arteriography to establish the diagnosis of arteriogenic cause of the erectile dysfunction.
Okay, so how about maybe from the another center, from the Dr. Yafi or Dr. Munir, how can you usually diagnose the erectile dysfunction? If you want to exclude the vasculogenic erectile dysfunction, how can you do that? Do you usually use the ultrasound with the intracavernous injection or not?
I mean,
yeah.
I mean, it depends on, what you're looking for here. I mean, if someone's got, quite obvious risk factors, say, for instance, they've had a radical prostatectomy or they've got diabetes, I mean, you don't necessarily have to generally do investigations to diagnose erectile dysfunction. It comes on the history. You've got risk factors, you look at the pattern of erectile dysfunction, you give them pharmacotherapy. It's only the complex cases that you'd want to do some investigations. So we tend to reserve penile Doppler studies for those who are either psychogenic in conjunction with an NPT. We'll do the two, just convince them that everything is all okay. We'll do it for those who've got potential arterial cause due to pelvic fracture or some injury in the pelvis. I don't think it's a great way to diagnose a venous leak, and I think a venous leak is probably overdiagnosed anyway. We tend to use NPT quite a lot instead because, we do have people with a mixed picture. The only time that we'll use a penile Doppler is preoperatively. So if they're going to go for surgery for Peyronie's disease or they're going to have a grafting procedure, we'd like to know what their peak systolic velocities are prior to any grafting procedure, because it gives you an outcome in terms of whether they can get erectile dysfunction post-operatively as well. So we try and kind of limit it to those, and also possibly those that don't need any major invasive treatment, just to convince them that everything looks okay. Remember that the penile Doppler is also dependent on who does it, so it's very operator dependent as well. And it's pointless doing a penile Doppler for erectile dysfunction without giving them Cabajet. You have to do it with a pharmacologically induced erection. So we make sure that we interpret the results depending on what kind of erection they got as well at the same time.
Okay. So how about Dr. Faisal Yafi? So I saw that you usually exclude the venous leakage with the ultrasound penile Doppler. So do you usually use it to diagnose the erectile dysfunction, all of the patients, with the ultrasound or not?
No, I mean, if every patient who walked through the door got a penile ultrasound, then you would not be able to keep up with the practice. So we also limit the use. So the patients are going to be the guys who are not responding to PDE5 inhibitors, for example, and whom you want to do injection therapy. So what we do is we do the ultrasound at the same time as we do the teaching for the injection therapy. So that's, you do both at the same time. We also do ultrasounds in patients who are doing injection therapy, but they're not getting good outcomes and they're considering a penile implant. So that gives us a little bit more of an idea about what's going on, whether we need to change dosing, etc. We do it also in I like to do it in the younger patients in whom, despite the reassurances that they don't have any psychogenic issues for their erectile dysfunction, we found some benefit in doing the ultrasounds and showing them on the screen that, you know, your blood flow parameters are normal. And then if you have your patients, you're not that commonly, but your patients who are post-traumatic, post-pelvic fractures, post-accidents, etc. And then most, if not all, patients with Peyronie's disease in our practice get an ultrasound. And the benefit here is, particularly you're looking for venous leakage if you're going to do any kind of grafting procedure, or if you're trying to discuss with them, you know, whether they're going to go through a plication procedure or they're going to go for an implant, depending on the response to injections. We also find it useful, the ultrasound, prior to starting injection therapy, because we are able to look at the plaque and see if the plaque is calcified or not. And in patients who the plaque seems to be pretty calcified, we won't offer injection therapy. So some benefits, I think we do a fair amount of ultrasounds. We see the benefit of them, but again, an ultrasound that is poorly done is absolutely useless, because again, everybody will end up with venous leakage if the ultrasound is not done properly, and if you don't re-inject the patients and take your time making sure that they have an appropriate erection.
Okay, so I think we discussed about the ESWT. So I think now we can discuss about the second topics about the penile prosthesis. We already have some questions. So maybe especially for the Dr. Asif Munir, there are some questions. So how about the average percentage of complication after the operation of the penile prosthesis? Is there any possibility of malignancies complication?
Did you say malignancy?
Yes.
No, not that I've never seen that. I mean, obviously, you know, we're not, we are using foreign material, but I don't think, you know, there's really any evidence that that will result in any type of malignancy or induce any, you know, carcinogenesis. So they're all being tested. The implants last for, you know, on average 15 years, unless they get mechanical, you know, malfunction before that. But no, I don't think, it's not something that we would counsel them for, that there's a risk of malignancy with this.
Okay, so regarding for the survival rate, so you usually wait for the 15 years to regularly to change, or you are waiting for the mechanical failure? After that, you will change the processes.
No, you don't have to change them according to, you know, if they're working at 15 years, you can just leave it. But
Okay.
it's just, you know, on average between 10 to 15 years, you know, there's generally some kind of tube breakage or some kind of reservoir leak or something. I mean, we've had implants which last, you know, more than that, a few decades. But generally, you know, if there's problems between then and, you know, obviously the 15 years, you know, we replace the pump, or we might reposition the reservoir, or the tubing might break. You just need to you know, change the cylinders. So it depends on the patient. You know, if they're happy with it, you know, just carry on going. But obviously with all sort of mechanical devices, there is a bit of a sort of lifetime shelf life on them.
Okay. So how about Dr. Yafi? I know that maybe US popular with the IMS, but it's different in the Europe. So I think in Europe, maybe Coloplast is more popular. So how about the experience you using maybe the IMS? So do you usually for the life years the medical failures will happen after the 15 years?
So I think the data for both devices is pretty comparable. In the US, there are potentially slightly more AMS than Coloplast. I tend to be a much higher volume of Coloplast than AMS in my practice, but this is just a personal preference of mine. I think the devices are very comparable, and in terms of when I counsel patients about device survival, I counsel them that the same as mentioned, about 15 years or so. And there's a new Italian study that came out, I can't remember this year or last year, showing that 60% of patients were still using their implants at 20 years. So and the data is pretty comparable between the two companies. So I don't tell them anything different whether it's an AMS or Coloplast device.
Okay. So maybe the question to the Dr. Munir, new question. So what is the routine examination to follow up the implant condition and position such as imaging? Do you have usually special examination to do the routinely exam for the patient like that?
I mean, generally, if it's not working, the patient will tell you that they're pumping up and it's not inflating. When you see them in the clinic, I mean, we tend not to follow them up, that regularly. We'll see them a couple of weeks after the implant for a wound check. We'll see them probably 6 weeks after that to make sure they're using for intercourse. We'll generally follow them up for 12 months. And if everything is all going fine, we just check that, in the clinic, it's cycling okay. So check the pump, squeeze it, make sure it's cycling and going down. Check the position of the tips with the glands, make sure there's no erosion. And, ensure that, there isn't any impending erosion or floppy glands or anything like that. So some patients complain that even though the implant is in, the glands just isn't quite getting full. So they might need some intraurethral, prostaglandin to try and get that glands a bit fuller. So they're the basic, examination. Then after that, if they're fine using it and they've got a dexterity, we'll just let them carry on until there's a problem. And if there's a problem, they will then get in touch with us. They have a nurse they can contact directly. We'll get them in the clinic and we'll see what the problem is. Have they got a leak and it's not working? Has, been a hole in the tubing somewhere and it's slowly leaked out? And then we'll just bring them in for surgery and just replace it. So that's the only thing that you need to do. So they're not high maintenance, really. Once it gets going, it gets going.
Okay. So there is a question about the mechanical failure. So can you explain us, is there any risk factors that can cause the mechanical failure?
I mean, so there's risk factors in terms of, problems with the device anyway. Where there were a string of pump failures we had with the AMS pump, where for whatever reason it just wouldn't, get going. I don't know whether it was a batch or whatever, but you just replace the pump and it gets going again. So mechanical failure is often the pump. Sometimes, it's breakages with the tubing, or a problem with the lockout valve. So, with these kind of things happen with any mechanical device. The other problems with mechanical failure is obviously surgical aspect. So has the surgeon, not put it in properly with the cylinders not fitting in the corpora? And when I showed you that picture of an S-shaped for deformity, that's, a surgical aspect. They've sized it incorrectly and the cylinders just aren't inflating. So that's, mechanical failure because of surgical aspect. Sometimes the reservoir is in the wrong place and it's not inflating, or it, herniates out. So these are all, basically to do with, who's put the implant in. And this is one of the reasons, there will be our national audit of penile prosthesis about to be published in BJUI, where we've looked at 1,071 implants, and you can see that our number of centers which are putting in implants now has gone down to about a dozen in the whole country. About 10 years ago, there were more than 30 centers putting in penile implants. So now you go into sort of higher volume centers, you get less of these problems because it's a routine. The staff are familiar with it, the surgeons are familiar with it, and I think you get better outcomes. And with us, obviously with the National Health Service, we put these implants in for free. We want to make sure that we get it right the first time rather than them coming back and having revision surgery, which is costly to our healthcare system. So I think centralization is the key, and they should be done in higher volume centers.
Okay. So another question regarding to the penile prosthesis. So is there any tips and tricks to prevent urethral rupture for the penile prosthesis procedure? And usually how long post-operative patient allowed to have intercourse?
So intercourse, we normally say 6 weeks after the implant. They can start cycling the implant after 2 weeks, but intercourse is at 6 weeks. With regards to urethral injury, I mean, again, it's just careful dilatation. So you stay lateral as you're going up the corpora. If you put a catheter in at the start of the operation, it goes in easy, you can proceed. But if you've got a stricture because they've had, prostate surgery or whatever, and then you need to optical urethrotomy, then you should deal with that, abandon the procedure, and then come back at a later date. So the main sites of urethral injury are either distal, which is often due to the dilatation incorrectly, or proximal, and that's more down to the dissection when you're, exposing the corpora, which you just need to be very careful with. Otherwise, I think the risk of urethral injury is very low. In our audit, I think there were only about 3 or 4 urethral injuries that were reported that required abandonment of the procedure. But then you leave them with a catheter for a couple of weeks. You can do a pericatheter uretherogram and then do the surgery 3 months later, provided there's no leak.
Okay, thank you, Dr. Munir. So we can go to about the mental health center. We have some questions. So to the Dr. Faisal, what's your opinion regarding ESWT for chronic prostatitis? Do you ever do to the patient like this, to do the ESWT for chronic prostatitis?
I have not done it yet. I actually have a patient I'm doing this week for the first time, but the data again is very soft for that. There are some centers who are doing it in the United States. I have not. I don't have much experience with it. Like I said, I'm doing my first patient this week. There is some the anti-inflammatory properties of Shockwave, as well as the increase in blood flow and decrease in like I said, inflammation, does portend to potentially benefiting in those patients. But again, I don't have much experience, so I can't tell you much.
Okay, so maybe Dr. Munir, do you have any experience for the ESWT for the
Yeah, I mean, there was some data that came out from Denmark with regards to one of their, I think it was a Storz duolith machine that they were using for pelvic pain. And they used to just, use this shockwave in the perineum. I mean, I myself have only tried it on a couple of patients, and I don't think it made that much difference. Again, did it in combination with using a PD5 inhibitor. I don't know whether it's just a modern version of doing a prostate massage that you used to do with your finger in the olden days. But I think, these patients who've got, genuine pelvic floor dysfunction are a difficult group, and I think targeted therapies such as physiotherapy, injections are probably better rather than, what we used to do or trying to do now, trying to target the prostate. I don't think that will, help the whole dysfunction, because you've got to remember the pelvis is a very vascular area. There's a lot of nerves there. There's a lot of muscles. So just targeting one area, I'm not quite sure is going to be the way forward.
Okay, so how about Dr. Poncho? Do you have any experience to do the ESWT for the chronic prostatitis?
Yeah, some patients have improvement, but like Dr. Yafi said, that the data is still not inconclusive yet. But in the patient with no option anymore, have a lot of antibiotics, analgesics, no improvement, then I tried to do the ESWT in the CPPS patient. But it's still on a few patients. I cannot have any suggestion yet.
Okay. So another question about the Rigiscan. Do you usually use the Rigiscan routinely to distinguish between the psychogenic and orogenic origin in your practice? Maybe Dr. Yafi?
So actually, the Rigiscan is almost practically impossible to get in the United States. It's not available commercially, so it's very hard, and it's only analog and it's old devices. So we actually Usually in the U.S., it's at this point, Regiscans are only used for medical legal cases where we're trying to prove that a patient still gets erections, or for study purposes if you're doing a clinical enrollment. So we don't use it, but I personally don't really see the huge benefit of the Regiscan. I think from a good history of a patient, if you look at their comorbidities and you talk to the patient, possibly talk to the couple and see if they're getting nocturnal or morning erections, you're often able to screen out any kind of psychogenic cause. And then we do the duplexes, the penile duplexes, as long as you're redosing the patient appropriately and making sure that you're getting at least a 70% rigid erection on your duplex, you're able to tell whether there's any kind of organic cause to the erection or it's more of a psychogenic cause. And then once we've kind of determined that it is a psychogenic cause, at that time in those patients we've always checked hormones, and we make sure we check a thyroid hormone as well as the main panel of androgenic hormones. If everything comes back normal, then we send them to the sex therapist, and the sex therapist can also shed more insight into whether it's psychogenic or not. We have a sex therapist, like I said, in our practice, so that also makes the discussion easier. We don't use Regiscans again in the U.S. It's only for medical, legal, and research purposes. I know some offices still use it, but it's very, very rarely used.
Okay, thank you. How about Dr. Munir?
Yeah, I mean, we use it still quite a lot. I mean, I think it's quite useful, I find, with the psychogenic young guys, just to prove to them there's nothing wrong, because otherwise they just end up going around in circles to lots of different specialists until they get the right answer. The other ones are, I mean, there are a young group of patients who have lifelong erectile dysfunction, and we've never really found a cause. And a lot of them get labeled as psychogenic. But actually, when you do the Regiscan or the NPT, they do have poor function. So I just think they've got, smooth muscle dysfunction for whatever reason, that you can't get a reasonable erection. And it just gives us a little bit more data before counseling them for a penile prosthesis, because they've failed pharmacotherapies and they've got no other option. Now, these young men, they're in their typically early 30s or mid-30s. They can either carry on with a life of struggling with their erections, or if we prove to them the NPT also shows poor erections, they come to terms with the option of penile prosthesis a little bit earlier, but there's a bit more justification for us to do the penile prosthesis as well. And I agree with Dr. Yaffe as well that we do them for medical legal purposes. We often do them for people who've got nocturnal painful erections as well, just to get an idea of how long these erections are lasting for. Combine it with sleep studies as well. So there's a few indications, and we have a couple of machines. I'm surprised I can't get it in the States, because I thought GoTop was the company that took it over and is doing refurbished machines as well.
Yeah, that's more recent. So now it's getting a little bit more available, but for a long time we couldn't get any access to it. Even when they did the trials, it was an issue. Yeah.
I think the problem was that they were also using operating systems which are from about 20 years ago. I think they were still using MS-DOS rather than Windows. So I think it's all
you still get those little green squares that are moving on the screen when you do them. So
yeah, exactly. So it just needs to be updated. I heard a rumor there is another company developing something as well. So
but which brand that do you usually use in the UK? Is it like the GoTop or not?
The GoTop took over Regiscan. So they took over, but they can't change the device, the casing. They can't change that yet. So what they've done is they've changed it internally, but they haven't changed it externally. It's the same box.
In the US, there's a development right now for basically, the Fitbit for working out. There's a new device which is basically like a Fitbit. We joke, we call it, excuse my language, a fit dick, but you basically can put it on the penis, and the patient wears it throughout the day and during intercourse, and it gives you all the parameters about, basically what we call plethysmography, which is how the penis is expanding and not expanding, and all that. Give you basically very similar to Regiscan, but patients be able to wear it throughout the day. and gives you a lot of information, including during sex. It's in development and it's Bluetooth guided, etc. So it's probably the next generation of what these things have. And I'm sure that's not the only device that's being developed, but at least that's one in the US that's in the works.
Okay. Yeah, because I think in Indonesia we only have the GoTop for the Regiscan, the only one Regiscan that we have. Okay, so maybe Dr. Poncho, can you tell us about the experience with the Regiscan? Because
Yeah.
I think, yeah.
I use the Regiscan for the young patient with the most probable is because of psychogenic to return the confidence of the patient and to make sure that that the best treatment is the psychotherapy. So before I send the patient to the psychiatrist, and then I have to make sure that everything is okay, only in your head is something wrong in the head, but not in your erection process. The second is for the legal purpose. I think I have 3 experienced patients asked by the court to prove that the patient is either it is erectile dysfunction or not. And then for the patient, if they fail with the medicamentosa treatment, and then I will suggest doing the Regiscan examination before we go to the next level. Because Indonesia, I said before that we don't have any injection medication, and it's difficult to get the vacuum erectile device. So the option is only for the medication and then the penile prosthesis. Before we go to penile prosthesis, we have to prove that the erection is not so good with the Regiscan examination.
Okay, so maybe we still have some, maybe at least 4 or 5 questions. So regarding to the presentation that from Dr. Yafi, you said that you always check the screening with the obstructive sleep apnea questionnaire. So is it related to the erectile dysfunction?
So there's some mild data relating obstructive sleep apnea to with ED, but there's stronger data for obstructive sleep apnea with testosterone levels. So there's some nice data from Baylor looking at shift workers, for example, and that if you have any disturbances in your sleep, so people who basically work at night and sleep during the day, their testosterone levels are off because of disturbances in the circadian rhythm. So, and also we have some data showing obstructive sleep apnea and testosterone levels, but obviously, of course, obstructive sleep apnea and nocturia are closely related. So there's, sleep represents, depending on how many hours you sleep per day, anywhere between a third to half of your life. So we really spend a lot of time focusing on sleep and making sure. So we do the 2 screenings, the stop bang, which is for sleep apnea. And it's a very easy, quick questionnaire, and it scores and it relates very nicely to the testing afterwards. And then we do the insomnia score. The insomnia score is also analogous to patients who are not sleeping well at night. But these 2 tests, these 2 questionnaires are very easy. They're you just take them as positive or negative. If they're positive, you just offer them a sleep referral. But you will get some patients, particularly the patients with urinary issues, who you send them to the sleep therapist. They get fitted with a CPAP machine, and the urinary symptoms improve significantly.
Okay, thank you. And so for all of the speakers, we have question about the comparison. How about if we compare the shockwave therapy and then the routine daily dose of the PDFF inhibitor and maybe stem cell? Do you have any experience about the comparison like that? Maybe if the erectile dysfunction is not so severe, in mild and maybe mild to moderate, and maybe it is vasculogenic, which do you want to prefer, to give the shockwave to the routine daily dose of the PDFF, or maybe, I don't know, you have any kind of experience with the stem cell?
I mean, I don't have any experience with stem cells myself, and the data, I think, is still very early with stem cells for erectile dysfunction. So it's not something that I advocate. But if I was going to give a PD5 inhibitor, I'll do daily dosing, 5 milligrams because long acting, you take it every day. And if you're having this concept of neovascularization, you're just going to try and improve that, endothelial response as much as you can whilst you're having the shockwave treatment. So I just do daily dosing and shockwave.
Okay, so how about Dr. Yafi? Which do you want to prefer?
So I agree with Dr. Mahir. The data for stem cell therapy is still very, very early. Again, and in the United States, where marketing always is ahead of science, there's a lot of stem cell therapy offered for ED, but there's no data to support it. So I don't offer stem cells, and I have no experience with offering stem cells. PDE5 inhibitors, I think it's a discussion with the patients. For the patients who are having intercourse, less frequently, we don't necessarily give them daily dosing. We recommend on demand, but for those who are having sex more frequently, then daily dosing certainly works because of the long activity of Cialis. And shockwave therapy, again, we're starting our experience with shockwave therapy in those patients. So again, it depends on the motivation of the patients, depends on what their erectile status is. Obviously, if a patient's responding to PDE5 inhibitors alone, then I don't think there is a need for shockwave therapy. Shockwave therapy can complement if the response is not perfect and you're trying to improve it. But I think with sexual medicine, I think it's very hard to put everybody in one bucket. I think you have to basically, every patient, you have to treat them as an entity, and depending on how what their goals are and how frequent their intercourse is.
Okay, so how about Dr. Poncho? Do you prefer to give the patient first with the daily routine of the PDE5 inhibitors?
Yes, I don't have data and experience about the stem cells. So I agree with Dr. Munif and Dr. Yafi that the stem cell in erectile dysfunction is not conclusive yet. For my patient, I usually give the PD5 inhibitor first before we go to the ESWT. If the response is good or partial response, and then I can do also the ESWT. Which one is the daily dose or once a day? It depends on the situation of erectile dysfunction. Usually, I try to give to the single or on demand first. If the reaction is good, and then we can continue to do the daily dose to get the new vascularization.
Okay, but I think I personally interested with the daily dose. If the patient is have a better outcome with the daily dose, until how many months that we can give to the patients with the daily dose? I mean that maybe the patient feeling better, because if we give the on-demand, usually we give the high dose, maybe like 100 Viagra, but sometimes the bad effects will happen to the patient, so patient can happily consume the daily PDE5. But until how many months that we can give to this patient? Is it because I read some papers that the ESWT can reduce the usage of the PDE5 inhibitors daily. I mean that we can tapering off the PDE5 the daily until the patient cannot totally not depend on the PDE5 inhibitor. So how about that theory? So maybe Dr. Munir, do you have any experience like that?
Yeah, I mean, we'd probably give them the PD5 inhibitor for the treatment period at least. So I tend to start it about a week before, because remember, it takes about 4 or 5 days when you look at the pharmacological profile to get into the system to the correct dose, and it plateaus. So I'll start a week before, keep them on it for the whole treatment period, and then probably just tell them to keep it going for another 2-3 weeks afterwards. And then say to them, well, come off the tablets and see whether you've had any improvement and whether you can get an erection without any PD5 inhibitor. So that's for the people that want to come off the PD5 inhibitors. However, if they're already on PD5 inhibitors but don't get a full response, then obviously they're going to need to carry on with the PD5 inhibitor even after treatment. So they may or may not still need them. So these are people that have been on PDE5 inhibitors for quite a long time, but they don't feel they're as effective as they used to be. So with them, they may come off it completely, or they might still need to take it, but they get a full response.
Okay, so how about Dr. Yafi? If you use it daily, is there any limitation of the time that maybe you can give to the patient?
Are you talking in a patient undergoing shockwave or general population?
A general population?
No, I don't
That
think there's any limitation on how long you can do. The long-term data for PDE5 inhibitors shows safety. I think as long as patients are not exceeding the the maximum dosing of the pills, there's no issue long-term. What I do is I offer patients all the options. The Cialis, the Viagra, everything is generic now, so everything is cheap, or the daily Cialis, and then we'll see what their preference. Again, for the patients who have sex, for example, 2-3 times a month, I just don't give them daily Cialis. I tell them to take a pill on demand. I just find from a cost-effective perspective, it makes more sense to just take on demand. But for the patients who are having intercourse 3-4 times a week, then you can do the daily. We also have patients who take daily and then on top of it, take on demand. For the guys who the daily doesn't work well enough, but they're taking it for EDN, for example, LUTs, and get occasional, and when they want to have sex, they need a little bit more of a boost. So we have patients who do daily Cialis and 100 milligrams of Viagra on demand at the time of sex, and I think that's fine as well.
Okay, so maybe Dr. Pocha, how about it?
Usually I follow tadalafil 5 milligrams daily dose I give for 12 weeks, but I ask the patient to come back in 1 month to see whether there's the side effect, and then to see whether there is a good reaction or not. If there is an improvement, although it's not maximal, although it's not as good as the patient expectation, but we can continue until the 12 weeks. 4 weeks first, and then we evaluate whether we can go through or not.
Okay, so last question for Dr. Yafi. So how about the patient sensation and ejaculation after penile prosthesis? Is it still intact, or maybe can damage or not?
So usually the sensation and ejaculation and ability to reach an orgasm doesn't change after the penile implant. There is, however, a little bit of a transition period for some patients where they go from having slight difficulty reaching an orgasm with an implant just because it's a new experience. One, because they might be having a little bit of pain with sex. Two is because, again, it's a new thing that they're trying, but also for some patients who are used to getting a spontaneous erection and then having sex with an implant. Sometimes a patient might not necessarily be aroused or wanting to have sex, but their partner tells them, all right, let's have sex, and knowing that the implant can work at any time and they'll have sex without being aroused. So they might have a little bit more difficulty reaching an orgasm. The one group of population of patients you want to be careful with is the diabetic patients. So 1% of patients who have a penile implant might have some chronic pain after the implant or discomfort, and it's usually neuropathic pain, and it's usually in diabetic patients. So these are the only population of patients that might have some kind of sensory changes after the implant, and they might feel some shooting pains on their penis or on their glands. So these are the only group of population in whom you might see some sensory issues. But otherwise, for the most part, for most patients, ability to reach an orgasm and ejaculate and sensation does not change with the implant.
Okay, so I think there is one question. This is the last question for all. So maybe this is especially for Dr. Poncho. So if we have the patient with the ED, with the history of diabetes mellitus, should we start the medication or surgical therapy after their blood glucose level normal, or just start right away? And the number two is, how many times do we need to observe the nocturnal erection to diagnose the ED? Is it 1 time or more?
Nocturnal penile tumescence diagnostic is usually for 2 times, but sometimes it's difficult, and then we only do the 1 time. About the treatment, if for the diabetic patient, we can do directly right away to do the treatment. We can do we know that the patient with that diabetes mellitus, the response of the PD5 inhibitor is lower compared to the patient without the diabetes mellitus. But we can start right away to do the treatment. In parallel, we have to control the blood sugar level in the patient.
Okay, so how about Dr. Munir? If you want to do the penile prosthesis, if the patient with the diabetes mellitus, how much the blood glucose level that you want to achieve before the operation?
Yeah, again, like I said, because we're doing them on our free, health service, they do have to have a criteria. So we have a HbA1c level of less than 9 that we have to, make sure the patients come in with. So if they've got poor diabetic control, we won't do the implant until the HbA1c is below 9. The BMI as well has to be below 30. They have to stop smoking. So yeah, for the inflatables, we're pretty strict on that. Otherwise, we just say that, we can't get it funded. And most patients are fine. They'll lose weight. They'll make sure the diabetic control is good. If, however, they don't quite lose weight or they just find it impossible, we'll offer them a malleable instead, because obviously that's less cost to our healthcare system. But, most of them do still go on to have an inflatable.
Okay, so I think because the time is, we over limit the time, we passed the limit time. So I think it concludes our discussion today. So I think we are very thankfully that Dr. Yafi, Dr. Ponch, and Dr. Munir have accepted our invitation. Thank you again. And I hope that this meeting we can collaborate together in the next time. So I hope that both of you and Dr. Poncho still stay safe because we are in the different countries, but maybe we have to be careful. Okay, so I think we can finish. So the meeting I will give back to the MC, Dr. Hosia. Thank you.
Thank you for the invitation now.
Thank you very much.
Thank you, Dr.
Have a good day.
Thank you, Dr.
you
Munir.
all.
Thank you, Dr. Poncho, Dr. Asif, Dr. Faisal, for all the very comprehensive and insightful topics, and also Dr. Widya Atmoko for moderating the very active discussion session. And now we are coming to the end of tonight's event. On behalf of the committee, I would like to thank PT Surgica Alkesindo as the sponsor of today's event. And again, Dr. Irfan, Dr. Poncho, Dr. Asif, Dr. Faisal, and Dr. Widi as our esteemed speaker and moderators. Everybody who is involved, and of course, all the participants of this event. There are around 500 participants in the first day of this event. So thank you all very much. And again, I am happy to let you all know that all the recordings of this event will be available on demand on YouTube channel Urologi FKUI RSCM. We look forward to see you all again on next Saturday in our Endo-Urology event. So I'm Hosea. Thank you. Good night, and let's jump 2020. Thank you.